Right, so because you already know that the INICET is mainly based upon the exam is usually they give most of PYQ and PITP previous year questions, and previous year topics play a major role. Can you all hear me? Yes. So if you all can hear me, then let's quickly start. Okay, now let's start with the very important and the first question. Okay, before that, there is a heads up for you all that we are starting the GTs, that is the grand test. You can attempt all these questions. Good evening, Arya. So you can attempt all these questions and you have to write minimum of 10 to 15 GTs before going to your exam. So GT play a very important role, as all your professors would be focusing on. So it is very important. So PW is presenting you with a lot of GTs. So I hope you will all make good use of it. Good evening, Abhishek. So let us quickly start. Am I audible and visible? Everything is clear technically, so we can start without wasting time. Okay, now this is the first question. So read the first question. Good evening, Arya. So coming to the first question, patient presented with bone pains and fatigue is being evaluated. Patient who's being presenting with bone pain and fatigue is evaluated. And now you see there is a high calcium. The calcium is high. So first the presence of bone pains, then there is a high levels of calcium, which is hypercalcemia, and phosphate is low. So this will teach you something very important. Whenever you say the calcium is high and phosphate is low, you have to immediately think of one important parameter. What is that? That is your PTH, right? So the PTH. Okay, now there is something related with PTH, and now let us see. So now the patient is also having generalized osteoporosis, so that is also taking you to the PTH. What is the best investigation for diagnosing the condition? So this is again an integration with the surgical side. So usually we don't deal with this investigation of choice, but here we are very much interested in knowing what is happening to the PTH, right? So whenever they say there is an increase in calcium and decrease in phosphate, that means this is a condition where there is an high levels of PTH, right? There is a high levels of PTH. And the second line, that is generalized osteoporosis, because the calcium is increased by the PTH. How? It will increase the bone resorption. So it will increase the bone resorption. By increasing the bone resorption, it will go and increase the calcium levels, right? And now this is mainly what? This is mainly your hyperparathyroidism. And if you have read enough PYQ, PYTs, you know that this important scan, the Sestamibi scan, is one which is very useful for identifying your adenoma. So identifying your adenoma is by your Sestamibi scan. I think it is repeatedly asked in various examinations, right? So the answer here is B, that is Sestamibi scan. Okay, fine. Now let us understand little bit of hyperparathyroidism, because as it is asked here, now they might ask you little different from the what the question has been asked. So let us understand what is an hyperparathyroidism. As you all know, there are three types. So the first one is called the primary hyperparathyroidism. The second is called the secondary, and you have the third one, the tertiary. Okay, so this is about your hyperparathyroidism. So whenever it is primary hyperparathyroidism, what you have to remember, it is directly because of the parathyroid problem. So there would be some problem with the parathyroid, as it is adenomas or hypertrophy, and this will cause increase in PTH. So as you all know, PTH is always in love with the calcium. So there will be an increase in the calcium, but as you all know, the like poles repel, so there will be decrease in the phosphate, right? So this is about your primary hyperparathyroidism, right? Coming to the secondary, why secondary usually occurs? Secondary usually because of the decreased calcium. So secondary usually because of decreased calcium, that is hypocalcemia will initiate increase in the PTH. So this is your secondary hyperparathyroidism. Okay, there are rickets. So whenever there is vitamin D deficiency, so all those will cause decrease in the calcium level. So decrease in the calcium levels will cause feedback mechanism, that is increase in the PTH. So this is secondary hyperparathyroidism. And what is tertiary? Tertiary is autonomous. So now because of a lot of continuous hypocalcemia will cause this parathyroid to become autonomous. So even though the calcium becomes normal, still there will be high levels of PTH. So this is your tertiary hyperparathyroidism. Okay. Yes, secondary could be renal failure. Very good. Yes. So now let us see what are all the features of this hyperparathyroidism, which is important from orthopedic prospect of view, right? So whenever there is an hyperparathyroidism, you should remember one dictum, that is there will be bone pains, right? Renal stones, abdominal groins and psychic overtones. So why actually this is happening? This is actually happening because of the hypercalcemia. So all this is happening because of hypercalcemia. Right, so all this is because of hypercalcemia. So whenever there is an increase in the calcium, why this calcium is increased from the bones? So there will be bone resorption and then they will cause rise in the calcium. So because of that, we'll have bone pains, right? And then this hypercalcemia in the urine will result in stones, that is your renal stones, nephrolithiasis, and then you have your nerve stabilizing membrane, that is calcium is important in the nerve stabilizing membrane. So there is psychiatric overtones, the mood swings, and then they also result in constipation, that is how the abdominal groins. So these are the signs and symptoms of hypercalcemia mainly. Right, and what will actually happen in the X-ray? If you see the X-rays, there will be subperiosteal resorption. So there will be subperiosteal resorption. That is mainly is seen in the phalanges. So you have to remember, whenever they put an X-ray of phalanges, especially on the radial side, if you see, there is a subperiosteal resorption and mostly seen on the second phalanges, right? So second phalanx, you see that's subperiosteal resorption, and you see the skull, you have the salt and pepper type of skull. So there will be salt and pepper appearance of the skull, right? And what is this? This is similarly something like the tumor. So what is this? This is an indication of what is called as the Brown's tumor. So what is a Brown's tumor? So Brown's tumor is nothing but there is, because of excessive resorption of the bone, there is a fibrous tissue which is present in the cavity. In the bone there is a fibrous tissue, and now whenever that bleeds, so this will form as a brown color, which is called as osteitis fibrosa cystica also. This is osteitis fibrosa cystica or the Brown's tumor. Right. So these are the features of your hyperparathyroidism. And as somebody said, the renal failure. Okay, secondary is renal failure. Kalaivanan. So there will be one important thing is the renal osteodystrophy, the end stage. So in that you can see what is called as the rugged jersey spine. So you will see the rugged jersey spine, which is seen in hyperparathyroidism and your CKD. Okay. So this is about the hyperparathyroidism. So to identify this, the first one, so this is the parathyroid adenoma. So to identify this parathyroid adenoma, we take technetium 99M Sestamibi. Okay. So this is the scan which is very, very important. You have to remember, it is usually asked repeatedly in many competitive exams, either as a general surgery question, but this time they have asked in this format. So the answer is Sestamibi scan. Following? Yes, now moving on to the next question. So what is the next question here? The next question here is, a patient presented with a history of fall on the outstretched hand and complains of pain in the left shoulder. Now the X-ray shows the empty glenoid. On an examination, you will find that arm is abducted and externally rotated. What is the most likely diagnosis? Is the video struck or you are able to see? Yes, or you are. Just a second. Arjun, can you put my image properly? I can't see whether the video is running or not.
No, video is running. I kept this for the watching.
Okay, that you little minimum. Like this you put, no? Because okay, done. Sorry for the small break. Kumar Abhishek, good evening. Alka Kumari, yes, thank you. Thank you for your confirmation. So the next question is, the patient presents with history of an outstretched hand and complains of pain in the left shoulder. So this is an X-ray they are given of the left shoulder, and now they have given the mechanism of injury also. So what is the mechanism of the injury? The mechanism, or what the on examination you find that there is an abducted and external rotated arm. So whenever there is an abduction and external rotation, what will happen to the shoulder joint? It will come out of the glenoid cavity. So this coming out of the glenoid cavity anteriorly is called as your anterior dislocation. So the answer here is, yes, the answer here is A, anterior dislocation. So given in the X-ray, given in the question, the mechanism of injury of anterior dislocation is abduction and external rotation. Abduction and external rotation. And whenever you see these patients walking with shoulder dislocations, you have to always analyze them with one important test. What is that test? That test is asking them to touch the opposite shoulder. So whenever they are unable to touch the opposite shoulder, that means there is some dislocation happening in the shoulder, right? So this is the one test where you will rule out as soon as the patient enters your casualty or the OPD, you ask them to touch the opposite side. So usually what they come holding the opposite hand, right? They come like this, and they won't literally allow you to touch. Okay, so this one test will help you to rule out that the touching of the opposite shoulder, the adduction is absent, the internal rotation and adduction is absent. Yes, you can comment on the, in the shoulder joint, usually we comment based on the AP views. In the lateral views, we can't see much in the shoulder. So usually what we do is shoulder is mostly reliable on the AP view. Okay. Yes, it can be fracture of the humerus provided the X-ray is given. The X-ray is given because to tell us what is this. No, this is not the fracture of the humerus, right? So here it could be fracture of the humerus also. There would be fracture and dislocation together. So there could be fracture plus dislocation. So that is why they have given you the X-ray. In the X-ray, there is no fracture given in the X-ray, and hence we conclude this as dislocation. But you have to be really careful before reducing it, because this might also present as a fracture. This might also present as a fracture. Okay. So before reducing or before diagnosing, you have to first take a proper X-ray, especially the AP view. You don't take much of lateral view, right? What will happen in the posterior dislocation? In the posterior dislocation, the mechanism is different. There is an adduction, internal rotation which will happen opposite to your anterior dislocation, and the whatever the head you see, it goes posteriorly. It goes behind the glenoid. So let me show you the X-ray. So if you see this is your anterior dislocation. So this is your anterior dislocation, and typically patient will say there is an history of trauma, and if you ask clearly, they say the mechanism is abduction plus external rotation, and you have your Dugas test to identify that the opposite shoulder adduction is not possible. So start touching the opposite shoulder or adduction is not possible, right? And now coming to this. So what is this? This is your posterior dislocation. Now this is your posterior dislocation. If you see the posterior dislocation, you can see the head is internally rotated. So because of adduction and internal rotation, you can see the head, the orientation of head. You see this is the head, the sphericity of the head. Okay, here you don't see that. So it becomes equal like this. So this is called as the light bulb sign. So this is called internally rotated humerus. This is called as the light bulb sign, and usually it is seen mainly in the patient suffering with epilepsy or during electric shocks. But still remember, the most common is your anterior dislocations. Okay, most common is anterior dislocation, but patients typically they present with epileptic patients or electric shocks. You see this type of dislocation, which is called as posterior dislocation or the light bulb sign. And then what is this? the third X-ray. So here if you see the arm here is hyper abducted. Here if you see the arm is hyper abducted, right? So this hyper abduction injury is nothing but your inferior dislocation, and typically the patient comes to the OPD with arm in abducted position. So they come to the OPD like this. So this is how they come to the OPD, stating that this is a case of your inferior dislocation. It is also called luxatio erecta. Okay, it is also called luxatio erecta. Okay. Yes, these are three types of dislocations: anterior, posterior and the inferior dislocation. In the anterior again you have subcoracoid, subclavicular types, most common being a subcoracoid. Okay, clear? So here the answer of this is your anterior dislocation. Yes, this is your answer, but yes, even it could be a fracture of humerus associated with it. That is why you have to always take an X-ray and observe. Okay, clear? Good. Moving on to the next. A 10-year-old boy with swollen arm. So there is a presentation of the swelling of the arm for 8 months. There is a raise of neutrophils and ESR, and now in the AP and lateral X-rays are given. Okay, lateral is missing here, only AP is there, and the next most appropriate investigation in management. So here what they are asking you is, they have given you certain clues and they are asking you how do you manage this case. So here the clue here is, first is the age of the patient. So you should always start with the age. The age is 10 years old boy. Okay, and the duration is 8 months, which states that this is something chronic, right? So this is something which is related to a chronic disease. And then most important, the neutrophils and the ESR is raised. So whenever there is a WBC increase, right, and then whenever there is an ESR raised, so it reminds you of something. It reminds you of what? It reminds you of the infection. But there is a catch here. So whenever you're dealing with infections in children, always clause. Remember, one of our favorite tumor, that is your Ewing's sarcoma, has to be ruled out. Because if you remember, in Ewing sarcoma also there is a chance of raised in WBC, raised in ESR, age being 10 years, patient might present with fever. So these are all the signs and symptoms of both your Ewing's and your infection. So to rule out which is what? So what is the ideal investigation? If somebody is asking you which one is the ideal investigations, so the answer would be your biopsy. But now they are asking you next. When somebody says next most appropriate investigations, so that would be MRI. So the answer is MRI. So the answer is MRI. Why MRI? Why not biopsy? So whenever we are dealing with infections versus tumor, the ultimate guide for us is biopsy. But before performing the biopsy, you should perform all the available tests so that you know what to do. So you have to plan the case meticulously, because if it is a tumor, you might damage the patient. You might result in damaging the structures of the patients, right? So that is why you have to take the proper MRI. Then you have to assess what is actually happening inside the body. So where is the lesion present? So how can we approach the lesion? If this is the Ewing's, how can we convert this into a surgery? So all this is required. So that is why next most appropriate, if somebody is asking you next best investigation is always your MRI. So you have to complete all the investigations available, right? And then you have to go for biopsy. But if this question was best or ideal, then the answer would be biopsy. The best investigation to find out, or the ideal investigation to do, or the ultimate diagnostic thing is your biopsy. Is that clear, Aryan? So wordings matter a lot. So read the question properly and then answer. So whenever somebody is telling the next best management, it is MRI. So after, if the MRI is also done, then you can go for your biopsy. Clear, Aryan? Yes, I'm waiting for your reply. Very good. Next best is MRI. So you are also in terms with us. So whenever we are dealing with diagnosis, you always start with age. So age is one important criteria you have to look for. Then after the age, you have to look for the clinical features. So they will tell you that there are certain clinical features which point out towards the tumors or towards your infection. So first age, then clinical features, then they will tell you the X-ray. So X-ray findings. So once they complete this age and clinical features, they might ask you what is the next thing you do. So we go for an MRI, or after MRI you have to confirm the diagnosis by either a CT or an MRI, and then after the MRI you go for the biopsy. So this is the order how we plan. Okay, and before the clinical and X-ray you can always include the lab investigations. So lab investigations usually we do before the X-ray or together. Okay, the lab investigation, X-ray or together, or first you can include lab. Once you come to arrive to a certain diagnosis, like for example this could be a tumor or this could be an infection, then you have to go for confirmation by CT or MRI, and then the confirmative definitive diagnosis is always by biopsy. What are the risk factor? Age. For what? For Ewing's. Ewing's usually we see in the first decade. So Ewing's is first decade, osteosarcoma is the second decade. So whenever we are talking with age groups of 10 to 20, like it is 10 to 20 years age group, usually it is osteosarcoma most common. When it is before 10 years, 9 years old, 11 years old, it is usually Ewing's sarcoma. What are the risk factor? Age. So age is a very important. So whenever I say age, if it is first decade, it is mostly in terms of Ewing's, right? And second decade is mostly in terms of your osteosarcoma, right? And skeletally mature, if the patient is skeletally mature, then your giant cell tumor, okay? Like that. The age is very important. And when the patient is above 60, so more than 60 years, elderly people, then you think of multiple myeloma, okay? Or you think of metastasis. So that is how the age plays a very important role in diagnosis. Okay? Yes, is that you were asking the risk factor? Now, let us tell a little bit of Ewing sarcoma again. So, Ewing sarcoma, the patient, again, we have told that it is the first decade of the patient, and you know it is males very much common, right? And it is the diaphysis part which is very much involved. So, the most common part of the bone which is involved is the diaphysis, right? You have to remember this, and you have to also remember that it presents as an infection where you see there is a fever with raised ESR, with raised WBC, right? And now after confirming, after MRI you go for what is called as biopsy, and before that X-ray. What is the X-ray changes? X-ray, you see the periosteal reaction which is called as the onion peel appearance. So it is like a layer, it is the onion peel appearance on the X-ray, right? Characteristic onion peel appearance seen in the diaphysis. Then when you go for biopsy, if you remember, it is a round cell. So round cells with the pseudo rosettes. These are called the pseudo rosettes. So round cell with the pseudo rosettes, and all these things like there is PAS positive, diastase digestive, and then MIC2 CD99 positive, and translocations present on 11-22 and 21-22. So all this information whenever they give, it is mainly suggesting of your Ewing sarcoma. Okay, whenever it is osteomyelitis, so usually it is acute osteomyelitis comparatively to your Ewing's, or sometimes these features of chronic osteomyelitis also. So usually when it is osteomyelitis, patients will start with fever, pain, right? And whenever you take the investigations, again there will be raised WBC, ESR and CRP, right? And then what you see here is mostly in case of acute osteomyelitis, the X-ray pointing towards the metaphysis. So infection is most common in the metaphyseal region, right? And then here also you take the CT and MRI, and on the biopsy what you find is the inflammatory cells. So you find the inflammatory cells and the new bone formation, right? So there will be inflammatory cells with some reactive bone formation. That is about biopsy in case of your acute. Okay? So that is the difference between your acute osteomyelitis and Ewing sarcoma. So moving on to the next question. A child presents with a closed supracondylar fracture. Very important, supracondylar fracture. In every exam there is a question about this, of the humerus after a fall. Okay, apart from the local pain and swelling, he is unable to make the OK sign with his thumb and the index finger. Which of the following structures is injured? So this is a direct INICET question. What would be the answer? So whenever you're dealing with supracondylar fracture humerus, the main important thing what you have to remember is there are certain complications associated with it, right? So the first important thing is the neurovascular injury. So the brachial artery and the median nerve, these are two vulnerable structures which are present during the fracture, right? So that is why whenever the patient arrives with the supracondylar, first you have to check for the pulsations. So to assess whether the radial artery is injured or not. Then you will assess the structures like your median nerve. So you will check for the sensations, then your ulnar nerve, right? So what is the answer? Yes. What is the answer? Is the radial, median nerve, ulnar or the brachial artery associated with the OK sign? So definitely not an artery because OK sign is not with the artery. Then what is the nerve which is associated with the OK sign? Yes, yes, quick. So this is the answer here is the median nerve. So the answer here is the median nerve. Okay, yes, whenever they give anterior interosseous nerve, the answer would be anterior interosseous nerve because anterior interosseous nerve which is associated with the OK sign. So anterior interosseous nerve is the branch of the median nerve and it supplies your flexor pollicis longus and flexor digitorum pollicis. Yes, very good. So it supplies the both flexor pollicis longus and your profundus. So that is why here what will happen is there will be formation of the OK sign. So if the AIN is not present in the option, the next best answer would be median nerve. Yes, very good. Median nerve. Yes, Amru, you have to remember AIN, then median, then ulnar, and last is your radial nerve. And this is depending upon the displacement. This is depending upon the displacement. So this is your supracondylar fracture, and remember supracondylar fracture is above the condyles, hence your 3-point relationship is maintained. So supracondylar fracture of humerus is above the condyles, hence 3-point bony relationship is maintained. So this is also asked in the exam. So your 3-point relationship is maintained in which of the following injuries? So the answer is supracondylar, right? And then they will ask you, it is mostly seen in the age groups of 4 to 8 years. So mainly seen in the age group of 4 to 8 years, right? And then see, depending upon the displacement, if it is usually what happens is extension type is the most common type. So there are two types, flexion and extension. So extension is the most common type, and Gartland classification. So you have this Gartland classification for the supracondylar fracture humerus, and whenever it is on the medial aspect, okay, so the median nerve and the brachial artery is one which is most commonly affected. So whenever it is brachial artery, you have to check for the radial artery pulsations. So you have to check for the radial artery pulsations, right? And then for the median nerve, what you do? You check all this. So what are all this median nerve? So you all know that the median nerve supplies what? It supplies all the flexors, right? It supplies all the long flexors, right? And then one of the most important thing what you see is the ape thumb deformity. So because of the thumb, because of the thenar muscles which are affected in the median nerve, you see the thumb is not in the abducted position and it goes in line with the fingers. Usually it is perpendicular to the palm. It goes in line with the fingers because of there is a loss of the thenar muscles, and what this is called as the ape thumb deformity. So in the median nerve, what we see is the ape thumb deformity, right? So this is ape thumb deformity. And then next you see what is called the pen test. It is called the pen test. So again you're testing the abductors, right? So this is called the pen test. So pen test you're doing, and then what you have your this. What is this called? This is called your benediction sign or the Pope sign. Again it is nothing but your pointing index, Pope sign and the benediction sign. So all are same. So what is a pointing index? What is a pointing index? So you all know that it supplies the long flexors like your FDS and FDP. John, this class is mainly focused on your INICET PYQ. There are certain serious students who really want to get a high yield out of this class. All these topics we can discuss in some other class, okay? So please ask something which is relevant to this topic, okay? Okay, now pointing index. What is pointing index? So pointing index is, you know, that the median nerve usually supplies the long flexors. So it supplies all the long flexors except your FGP medial side and your flexor carpi ulnari. So these two are supplied by your ulnar nerve. So this you have to remember, right? And now whenever you see, whenever you do this particular closure of all the fingers. So this flexion of the fingers is mainly because of your nerve, your median nerve, right? So now what happens? Because the median nerve is supplying the flexion of all these fingers, what is happening is exclusively the index finger. So in the middle finger, it is somehow pulled by the FTP of this, of your third and your little finger, but index finger is exclusively supplied by your median nerve, the flexors of the index finger. So whenever you're trying to do this, whenever you're trying to flex all the fingers, you see that the flexion of the index finger is not fully done when compared to the other fingers, and this will result in this pointing index. So you will see something like the finger is not flexing, and this is called pointing index. And similarly, instead of using both the hands, if you try to flex or make a fist, you make a fist like this. So these two, because the little finger and the ring finger are supplied by also the FTP, so there is some amount of flexion which is happening, and this is somewhere attached to the third, and then the middle finger is also somewhat flexing, but you still see the index finger is still not completely flexed. So this is what is called your benediction sign. So this is called a benediction sign or the Pope's sign. So all these things, and this is also called as your Oshner's clasp deformity. Okay, Oshner clasp deformity. So this is what all you have to remember. So for the median nerve, so for the next coming exam, they can ask you that this particular supracondylar has been injury had happened. Now the patient presents with loss of pentest. So again the answer would be median nerve, or the patient presents with pointing index. So now they have asked you the OK sign, and now here they can ask you any other sign. So these are all the signs of your median nerve. And finally, the branch of the median nerve, your anterior interosseous nerve, and this is your OK sign. Or there is one more name which is called as Kilonavin sign. Kilonavin sign. So this is nothing but both your flexor pollicis longus and your first FTP has to come together to make an OK sign, right? So this is nothing but your OK sign. Fine. So this is about your median nerve. Okay. Yes. Yes, this was the recent question which was asked in the INICET. So can somebody answer this? So what is equinus? So to answer this particular question, so these are the deformities of ankle and foot. I'll make you it easy, because you can either think of CTEV, because you go prepared for CTEV, right? So CTEV, you know what are the deformities? You know, cavus, then you have your adduction, right? Then you have your varus, and then you have your equinus, and you know two of them out of this, right? Almost you know. So equinus, cavus, you know. So equinus is the what? There already you know the equinus walking on the foot. So it is like the horse. If you see, the horse walks on the toes. So walking on the foot. How do you walk on the foot? You have to completely plantar flex the foot. Then only you can walk. So that is your equinus. Then the second one you can answer is the cavus. So cavus is what? So cavus is something where the arch is increased. So it is a high arch foot. This also you can understand with the CTV, because CTV foot is something like this. So if it is the foot is something like this. So there is a arched foot. So high arch foot. So just let us match with A2. Yes, A2 and C4. A2 and C4. So the answer directly comes with option A. So whenever you see such questions, don't first get panic. Try to eliminate them, try to attempt them, and then you can easily find the answer. Now I'll teach you what is planus. So planus is nothing but it is opposite of cavus. So whenever you see cavus, I told you it is a high arched foot. But what is planus? Planus is nothing but low arch, or arch is absent, and this is called as the flat foot. This is called as the flat foot. So pes planus is nothing but flattening of the arch. So planus is flattening of the arch. So A is 2, right, and B is 3. D is 4, and now the calcaneus has to be dorsiflexion of the foot, which is opposite to your equinus. Is that clear? So now remember, so whenever you see a foot walking, foot on the toes, so toes down pointing downward, it is equinus. toes pointing upward, that is the foot is resting on the calcaneum, hence this is called as calcaneus. So this is called as calcaneus. Okay, so that is dorsiflexion of the foot, right? And then what is cavus? Cavus is, yes, cavus is high arch. So you have two arches, right? Medial longitudinal arch. So this is one important arch. So if you see the medial longitudinal arch, everybody has that arch, and this arch is nothing but causing the cavus means there is high arch. The when it is planus, planus is nothing but your flat foot. So the arch will decrease. So this is called as the flat foot. Arch is nothing but your flat foot. So the answer goes this way. Fine? Yes. Yeah, now you can see by yourself the answer here. So I have told you this is CTEV. So CTEV is this. So there are 4 deformities in CTEV, you have to remember. So what are those deformities? You remember with the mnemonic KAVE. So K is for cavus, A is for adduction, V is for varus, and E is for equinus. Okay, so this is what the deformity is, and how do you correct it? You correct it with a technique which is called as the Ponseti technique. So the correction is with the Ponseti technique, right? And how, when you start the casing as immediately as possible. Okay, even the first day or third day also you can start. Of newborn, first day of life also, as early as possible you have to start the treatment for CTEV. So this is one of the important question which was asked, what is the ideal time to start the casing? So what you do, casing, serial casing you do. So this serial casing is done by your Ponseti technique. So serial casing with manipulation. Okay, you manipulate the foot and you put case. You put the cast. So manipulation with serial casing or casting you do, and that is how you correct the CTV. So these are the deformities. If you see, this is arch. So if the arch is flat, this is called as planus. Okay, arch is flat is planus. Arch is elevated, this is called as cavus. Okay, and you see forefoot, it is adducted. Forefoot adduction. So this adduction of A is seen in the metatarsal, that is the forefoot. Then you see the equinus. Equinus is mainly seen in the ankle where there is a contraction of the tendo-Achilles. So TA tendo-Achilles gets contracted and hence it goes into plantar flexion. So this is your equinus. So plantar flexion is equinus. And then your varus. So you have inversion and eversion, right? So whenever it is inversion is varus. You remember CTEV is inversion, right? Varus. And opposite is eversion. Eversion is valgus. And this happens in the hind foot. So it is near the calcaneum. So here the calcaneum is involved. So this is in the hind foot. Okay, understood? In the hind foot you see the inversion and eversion. So the calcaneal, the subtalar joints are involved in varus and valgus. In the ankle, it is because of the tendo-Achilles, there is an equinus. And cavus is the arch. On the medial side, the arch is present, and whenever there is an elevation of this arch, cavus. Adductus is seen in the forefoot. Okay, in the forefoot, you see the adductus because of the metatarsals get adducted. So this is called as adductus. Yes, so once you correct this technique by Ponseti, and for the maintenance you use the foot abduction orthosis, which is called as Dennis-Brown splint, and once the child walks you use the CTEV shoes, right? So these two are the splints which are used in CTEV. And then if it is not corrected, then you go for your posterior medial soft tissue release, and still as the patient ages, then you go for your bone correction, that is your osteotomies. Yes, Kalvai. Fine. So this is about the answer. So again I have put everything for you. So this is equinus, this is varus, cavus, planus, valgus, calcaneus. Okay. So this is very important. I am like predicting this will be asked again. So I have given detailedly. So if you see, equinus is toe touch. And this calcaneus, if you see, this is heel touch. So the entire foot is on the heel, on the calcaneum, and this is called as the dorsiflexion. Okay. And if you see, varus is inversion and your valgus is eversion. And where this is happening? It is happening in the subtalar joint, the calcaneum. Okay, and this is happening at the ankle. and it is cavus is the midfoot arch. So in the midfoot you have arches, and whenever this arch is flat, this is planus, and increased, it is called as cavus. Okay, I think it is very much clear. Yes, moving on to the next question. This is very important again. So this question, patient presented with the rheumatoid arthritis directly given, identify the deformity. So very, very important topic, that is your rheumatoid arthritis. So what happens in rheumatoid arthritis? Rheumatoid arthritis is an inflammatory condition. So inflammatory condition matlab it is an autoimmune disease. So autoimmune means already your body, whatever the antigens are present, the body in the body itself. So the self antigens are produced in the body, and the body reacts to those antigens and produces antibodies, which is called as the RA factor. So this antibody is the RA factor, and now this RA factor destroys certain parts of the body, especially your cartilage, especially the cartilage, resulting in what is called as arthritis. So resulting in arthritis. So whenever the patient presents with rheumatoid arthritis, so what you have to remember is, first you see most commonly in the females, and the questions already start with the morning stiffness of more than 1 hour. So you will see there is a morning stiffness of more than 1 hour. Okay, and you have to always see there is an involvement of hand joints, that is smaller joints are involved. So whenever there is an involvement of small joints, especially the hand joints has to be present, and most importantly it is a symmetrical disease. So you will see the involvement of symmetry. Okay, both hands, both legs, both knees. So all these are symmetrical. So these are all pointing towards your rheumatoid arthritis. So the patient will be a female with morning stiffness, hand joints involved, and especially what are the most important joints which are involved in your RA factor? This is also an important question, that is your MCP. So MCP has to be involved, the PIP has to be involved. Which joints are spared? The joints which are spared are the DIP. So DIP are spared in your rheumatoid arthritis. Okay, DIP are spared, but your involvement of MCP and involvement of your PIP is present. And yes, the antibody is your RA factor. So what I told you is the antibodies. So there will be RA factor, and now there is a specific antibodies which is called as anti-CCP antibodies. Okay, so you are testing the anti-CCP antibodies as well for the specificity of the rheumatoid arthritis. And how is rheumatoid so special? Because I have told you it is a self autoimmune disease. So the degeneration is very fast. So the disease deformity is very fast. So you will see various number of deformities. The most common is being two deformities. One is called the bottinius deformity. The other one is called the swan neck deformity. So one is called the bottinius deformity. The other one is called the swan neck deformity. So what is a bottinius deformity and swan neck? So when it comes to swan neck deformity, you see there is a flexion at the DIP, right? And there is an extension at the PIP, right? So remember it as FG. So flexion at the DIP and extension at the PIP. So that is your swan neck deformity, exactly opposite to it. So what is this? It is flexion at the PIP and extension at the DIP, right? So that is your bottinius deformity. And what you see here, so you see there is a flexion at PIP and extension at the DIP, exactly opposite to a swan neck. So remember, swan neck is something like this. So remember the image. Okay, this is the image. Okay, yes, so this is your bottinius deformity. So this is your bottinius deformity, right? And swan neck I have already told you. So what is a Z deformity? Z deformity is a combination deformity of the wrist and the hand. Okay, and then what is piano key sign? Piano key sign is usually seen in your distal radio-ulnar joint involvement. So whenever there is an involvement of your DRUJ, how do you know? So you press both the bones, radius and ulnar, you move them up and down. So they keep moving up and down. So that is called your piano key sign. That is called your piano key sign. Okay. Yes, so that is about your deformities in the rheumatoid. Z deformity is a combination. So there will be a deviation of the metacarpals to one side and fingers to the opposite side. So that is the Z deformity. Okay, and this is the bottinius deformity which they are showing. Okay, very, very important. Why median nerve has come up now, Praveen Khade? Okay, so that is about the rheumatoid. Now moving on to the next. So this is very important. The 78-year-old patient has presented with the IT fracture. What is the treatment? So IT fracture is intertrochanteric fracture. Very, very important and frequently asked. So intertrochanteric fracture or IT fracture. Okay, so what could be the treatment of this? Is it hemiarthroplasty or a femur intermedullary nail or a proximal femoral nail or a derotation boot? What would be the answer? Yes, quickly, I want everybody to answer. Yes. Now going back to what is actually the femoral neck fractures, very important topic. So coming to the femoral neck fractures. So what will actually happen in the femoral neck fractures? Let us see. So whenever they want to test your knowledge, they will ask you this question. So there are two important fractures in the proximal femur. So one is called the IC fracture, that is intracapsular fracture. The second one is called the IT fracture, that is intertrochanteric fracture. The both are nearby. So if consider this as your proximal femur, right? The proximal femur, and you see the capsule is attached till the intertrochanteric ridge. So this is what the capsule attachment is. So capsule is completely attached here. Okay. So because of the attachment of the capsule, what will happen is they have divided it into intracapsular. So the fracture occurs somewhere here, and then they have divided into extracapsular. Extra matlab it appears somewhere here. Okay. So this is intra, this is extra. So intra is IC fracture. Intra is IC fracture and your extra is your IT fracture. Is that clear now? Okay, it is IT matlab intertrochanteric. So this is greater trochanter, this is lesser trochanter. So in between the trochanter, if the fracture appears, so that is called your IT fracture. So that is called your IT fracture. So now I'll clearly write here, you see. Okay, let's take the first IC. So if the fracture is happening at the neck, okay, so this is your IC. And if the fracture is happening in between the trochanters, so this is your IT, that is extra, because the capsule is attached till here. Okay, now clear? So whenever they ask you IT fracture, that is intertrochanteric or the extracapsular fracture, the answer remains the same for any age group. It is the DHS, dynamic hip screw, or PFN, proximal femoral nailing. Okay, is that clear? So we are sorted with IT fracture. Right now, let us see what happens with IC fracture. So these are the types of IC fracture. So the IC fracture can be just below the subcapital, or it could be midline, or it could be basicervical. So there are three types of IC fractures. It is subcapital, just below it, okay, or it could be basicervical. Okay, or it could be in between those two, subcapital, basicervical, right? And now whenever there is an IC fracture, it usually depends upon the age group. So first you see the age of the patient. If the age of the patient is somewhere less than 50 years, or if it is somewhere 50 to 65 years and more than 65 years. Okay, so you will give the treatment of the patient depending upon the age. Okay, yes, it is very common in the elders. Both are common in elders because of osteoporosis. Now, whenever it is less than 50, the treatment is osteosynthesis. So, what do you mean by osteosynthesis? That means you will try to unite the fracture, and this is by your CC screws. So osteosynthesis is nothing but you're trying to unite the fracture. So there is a fracture and you're trying to unite it, though that is called by CC screws. And whenever it is 50 to 65, there is a high chance of AVN. So you want to replace it. So you want to replace the femoral head. So this is called as the hemiarthroplasty. So this is called as the hemiarthroplasty, right? So that is called as the hemiarthroplasty. You can see, right? And then if it is more than 65, still you can go for hemiarthroplasty. And if the patient is an active individual, with the acetabular changes. So if there is an acetabulum changes that is showing degeneration, then you can go for THR. That is total hip replacement. That is total hip replacement. Very, very important. You have to understand this. So whenever the age is above 50 or above 60, there are high chances of avascular necrosis. Why avascular necrosis? Because of the peculiar arrangement of the blood supply. So the blood supply which occurs to the femoral neck is from distal, from here. It goes from here and through the capsule it goes like this. Okay, so whenever there is a fracture, if you see the fracture is here, so they will break the blood vessels, and now this part will go into avascular necrosis. So now you want to replace that part. So replacing that part is by your hemiarthroplasty. So this is your replacement of the head, right? And now if the patient is very much very active, more than 65 years and still active individual, but you also see that there is a degeneration in the acetabulum. So you can go for one more interesting operation, that is your total hip replacement. That is your total hip replacement, which is called as THR. But what is this? This is only half replacement, only of the femoral head, where we are replacing only half of the head, half of the joint. So hemi is half, arthro is joint. So half joint is replaced, and what is that? That is your femoral head is replaced. That is hemiarthroplasty. Now you see, if the patient is below 50 years, there is one more surgery which is called as the osteosynthesis. That means you are trying the fracture to unite. You are trying that the fracture will unite. You will do this with a technique which is called as the CC screw. So this is cannulated cancellous screws. Cannulated cancellous screws are used. Okay, and why these are called cannulated cancellous screws? So you will see this is a screw, and this screw will have a opening inside. So there is a canal which is open, and in this canal you can put a guide wire. So you will put a guide wire first, you will reduce the fracture, and over that guide wire you will put the screw. Hence this is called as cannulated. So there is a opening, there is a tract inside the screw, hence it is called as CC. That means cannulated cancellous screw. So these are half threaded cancellous screws. Why we use half threaded? So because we want the thread to be outside of the fracture. So that these threads has to cross the fracture. So because of that, there will be compression of the fracture, right? So this is the CC screws fixation, and this is your total hip replacement. You are replacing the acetabulum and the femoral head. So you are replacing the acetabulum and the femoral head, hence it is called as your total hip replacement. Total hip replacement. So this is all about your IT fracture, very, very important, and they keep on asking how to identify IC fracture on the X-ray. So this is the identification of the IC fracture. You see there is a fracture in the neck. So this particular area is the neck, and this is your trochanter, right? So if it is in this area, it is IT fracture. So if you see this, so exactly it is between the trochanter. So this is your IT fracture, and it is in the neck, here in the neck. So hence this is your IC fracture, right? Clear everybody? Hope you will not make any mistakes regarding this question when asked in the exam. Okay? So this is the neck. So if there is a fracture here, it is IC. If the fracture in the trochanter, it is IT. For IT fracture, the treatment is two. One is your DHS, that is dynamic hip screw. That means you see a plate with a screw. So plate plus a screw. So where the screw will be? The screw will be in the head. That you have to look for. Whenever there is a screw in the head. Similarly, PFN. So PFN is nothing but nail with the screw. So when you see nail with the screw, where the screw is in the head of the femur. So this is maintaining your neck shaft angle. So here you see the screws which are into the head, right? And a nail into the canal. So this is a proximal femoral nail. Yes, and if you see a plate with the screw, there is a plate, and this is the plate and the screw in the head. So this is the plate and there is a screw in the head. So this is called your dynamic hip screw, right? So this is your DHS, not to be confused with your other types of nails where these screws will be in the shaft only. So here you see the screws are into the head. So whenever you see the screw with the head, nail is present, it is PFN. Plate is present, it is DHS. So that is why there are questions, identify the implant also. So this is very clear you have to be, and this is the algorithm. Here you have to identify which age group they are presenting with the IC fracture, and then you will write the treatment. Is that clear? This is PFN. So the treatment of your IT fracture would be, yes, proximal femoral nail. So the answer is your proximal femoral nail. Okay, hemiarthroplasty is for your IC fractures. Okay, and then your femoral intramedullary is for femur shaft fractures. So whenever you have femur shaft fractures, then you go for nails, right? So you go for the nailing. And derotation boot. What is a derotation boot? Derotation boot is nothing but it is a conservative treatment. So what actually happens in the IT or IC fracture? There will be rotation. So the capsule is not, if the capsule is still present in case of IC, capsule is still present, you will see there will be an external rotation of the limb because the proximal femur there is a fracture. So the distal part will go into external rotation to maintain neutral position. To maintain the neutral position of the foot, they used to give this derotation boot. So derotation boot is nothing but a boot which will not allow the foot to either go external or internal. So there is something, they will put a bar like this and then there is a boot. Okay, so this bar is present in the neutral position so that the leg will be in the neutral position like this. So usually if there is a fracture, it tends to go into external rotation, right? So now we are bringing it to neutral and putting a boot with the rod down. So with the help of a rod, there is no movement happening. So that is your derotation boot. Clear? Yes, very good. Hope you will write this answer correctly in the exam. And next, one more trauma case. Yes, thank you. A 35-year-old male man falls on the outstretched hand, tenderness and swelling in anatomical snuff box. So something, whichever they are telling, some important keywords these are. Whenever they are talking about this anatomical snuff box in a patient of outstretched hand. So there is a trauma in anatomical snuff box, clearly indicating that they are talking about an important carpal bone, this scaphoid. And scaphoid is very, very peculiar of certain things. The peculiarity of the scaphoid starts with right from its shape of the bone, which is scaphoid, boat shaped, and then the vascular supply, it is again from distal to proximal, similarly like your proximal femur, hence there are high chances of it undergoing avascular necrosis, right? And one more interesting thing is, usually because it is a small carpal bone, the diagnosis of scaphoid fracture is usually missed. So we will usually miss the fractures, and here we have to remember certain things to not the miss fracture. One is your tenderness in the anatomical snuff box, tenderness in anatomical snuff box, and the second one what you have to remember is the oblique view. Okay, so once you find there is a tenderness in anatomical snuff box, now you are directed to take an oblique view of the hand. So this oblique view of the hand will correct us. If you take just an AP view, it is not possible to identify the fracture, but you have to take an oblique view. So this is an AP, so tilt, this is called an oblique view. So these two are important whenever there is tenderness and the oblique view. And now here they are telling that the X-ray taken in oblique view is also inconclusive. Then what is the treatments and what is the treatment? So whenever you're dealing with scaphoid fracture, the scaphoid fracture is dealt little separately because sometimes the fracture is not visible. Right, and now what you do, you discharge the patient, you go for an urgent CT scan, or you put a cast, or you take an MRI for ligamentous injury. Okay, now let us answer to Arya as he told MRI. So usually whenever there is an outstretched hand and tenderness present in the anatomical snuff box, it tells us that there would be a scaphoid fracture more than the ligamentous injury. So ligamentous injury can be present, but usually it is a chronic condition. So usually it is a chronic. Once you take an MRI and you don't find a scaphoid fracture, then you go for the ligamentous injury. So usually commonly diagnosed. So when you commonly diagnose it, then you will be commonly correct. When you rarely diagnose something, so you will be rarely correct. So first, common diagnosis first. Whenever there is a tenderness in the anatomical snuff box, you have to think of scaphoid fracture. And now, because the X-ray is not showing anything, that means what you have to do, you have to put a cast treating it as a fracture, and you have to do a follow-up after 14 days. Okay, and then if the patient is still not happy and even of the follow-up, you go for an MRI and then you will identify it as ligamentous injury. Okay, but for now the answer remains as the cast, thumb spica cast or a glass holding cast, and you have to come for the follow-up after 14 days. Okay. Right, Arya, is that clear? And you don't need an urgent CT scan until and unless the patient demands a diagnosis. So, if the patient is seriously wanting an answer for the question, then he can go for an urgent MRI or CT scan, and never discharge with analgesics. This is not anesthesia, this is discharged with analgesics. So, never discharge with analgesics because you might miss the fracture. So, what usually we tend to teach, or what our seniors taught or our professors taught, is whenever you're dealing with scaphoid fracture, be little, vigilant, and if you feel there is a tenderness, you have to always go for a cast application and you have to follow up the patient, right? So, once you follow up the patient and still the patient is complaining about the pain, then you go for an MRI, and on the MRI you will identify that there is a ligamentous injury, but immediately you don't go for a ligamentous injury, that means MRI. You immediately don't go for an MRI. Okay. So, the next step or the treatment here remains as glass holding cast and follow up. Is that clear? Yes. Thank you. Then, so this is your glass holding cast. So, this is called the scaphoid cast, and they might ask you to identify the glass holding cast, and what is the clue for it from the Colles cast? You can see the thumb is included. So, you have to see the thumb is included in the scaphoid cast, whereas in the Colles, the thumb is not included. The thumb is free. When you see a Colles cast, the thumb appears to be free. Okay, this is very important. Sometimes they give what is this. So, you have to identify which cast it is. So, to identify between Colles and glass holding cast, remember the thumb is included in the glass holding cast, in the Colles the thumb is free. And this is the oblique view which we see on the scaphoid, and here you can see small amount of disruption, right? Small amount of disruption is present, and you see the scaphoid is clearly completely visible in this oblique view. If it is a normal AP view or a PA view, you can't get this orientation of the scaphoid. So, remember what is the view which you ask for this? You ask for the scaphoid. So, X-ray 10 to 14 days or some, yes. You can, yeah, after once the cast is done for 10 to 14 days, you can sometimes visibly see the callus, or sometimes the fracture gets identified. Before the 10 to 14 days, because of the edema or because of the pain, the patient does not make us see properly, but after 10 to 14 days, sometimes the fracture will be visible, and that is the time where you can go for MRI or a CT scan for the diagnosis. Okay? Yes, next. The 13 years old presenting with the sunburst appearance. So, this is a very straightforward question, and I know everybody who is appearing for this exam will write this question correctly even with the closed eyes. So, what is a sunburst appearance? Codman's triangle. So, these are very, very important things. So, sunburst appearance and Codman's triangle are very commonly seen in one important condition, that is called your osteosarcoma. Osteosarcoma. But please don't rely only upon the periosteal reaction, because the periosteal reaction can be seen somewhere else also. So, this sunburst appearance can be seen in Ewing's also. So, don't slowly depend upon your periosteal reactions. Read the question properly, because here it's second decade with the sunburst appearance, and not all other options are there which can make the sunburst appearance, but because of the age group we are going with the osteosarcoma. So, the answer is osteosarcoma. Yes, very good. So, the answer is osteosarcoma. But remember, Ewing's also sometimes might present as a sunburst appearance. Okay, you have to read the question properly. And what is the sunburst appearance? This is nothing but, what is this? It is nothing but, what is osteosarcoma? It is a bone forming tumor, right? So, it is a bone producing tumor. So, this tumor will produce the bone along the Sharpie's fiber, along the Sharpie's fibers or along the vessels. So, when these vessels and Sharpie's fibers are oriented radially like this from the tumor, they appear as the sunburst appearance. They appear as a sunburst appearance. And what is Codman's triangle? So, there will be an elevation of the periosteum at a certain height level, and there you will see that there is a formation of triangle. So, this formation of the triangle is called as the Codman's triangle. So, here you can see the both. So, this is called the sunburst appearance. So, you can see that the formation. So you have to remember the osteosarcoma is the bone forming tumor. That means you can see there is a bone formation. Even on the biopsy you see osteoid on the biopsy. So this osteoid which is deposited in the tumor is along the Sharpie's fibers or the vessels, giving you appearance of the sunburst appearance. And here you see the periosteum is slightly elevated like this, and this will give you an appearance of the triangle. This is called as the Codman's triangle. So slightly the periosteum is elevated, and this is called as the Codman's triangle. So these two are very definitive of your osteosarcoma, provided the history is very correct. And what about your fibrous dysplasia? Shepherd-Crook deformity. This is also very, very important. Whenever they ask you where you see the Shepherd-Crook deformity, so that is your fibrous dysplasia. Don't forget Shepherd-Crook deformity. Right, so why the bone marrow is completely replaced by the fibrous tissue, and you will see that there is a Shepherd-Crook deformity which is seen in fibrous dysplasia. And they have even asked you McCune-Albright syndrome. So what is McCune-Albright syndrome? Whenever you see this fibrous dysplasia in multiple places, that is polyostotic fibrous dysplasia along with precocious puberty, you see capillate spots, and all these are present in one important syndrome which is called as the McCune-Albright syndrome. And this is also an important MCQ. So what is an McCune-Albright syndrome? It is a syndrome associated with your fibrous dysplasia, and you will see capillate spot with the precocious puberty and polyostotic fibrous dysplasia. Fine. Osteochondroma. What is osteochondroma? Osteochondroma is nothing but excessive growth. So if this is your jaw, this is your femur and you see something growing, the bone growth, excessive bone growth, this is osteochondroma. This is also called as exostosis. So this is also called as exostosis, and multiple exostosis are present, and this multiple exostosis is also called as diaphyseal achalasia. So this is also called as diaphyseal achalasia. What is the treatment for osteochondroma? Excision. So you excise the osteochondroma. What is the instrument which is used here? The instrument which is used is your osteotome. So bone osteotome is used. So this was asked in the exam. The instrument used in the excision of the osteochondroma, it is the bone osteotome. Okay. So these are all MCQs. These are all MCQs. And Ewing sarcoma, you see end on appearance, and you see the periosteal reaction, that is your onion peel appearance. Clear? Yes. The next one. This is little bit tricky. I'm not very sure about this. But somehow I wanted to discuss. A 12-year-old boy presents with pain and swelling of the left leg. So there is a pain and swelling of the left leg, and on examination leg is swollen and warm. X-ray shows sclerosis surrounded by lucency. What is the diagnosis? Whether it is associated with the E. coli, streptococcus, mycobacterium tuberculosis or Klebsiella. So what would be the answer? So here what they are trying to test the knowledge of infections along with your microbiology, okay, or something they wanted to integrate. So here what they are trying to tell you is the osteomyelitis. So they want to talk about osteomyelitis along with their organisms, a very important favorite topic. Okay, so this is a 12-year-old boy, pain and swelling, and there is warm and swollen. So already there is a high chance of osteomyelitis, and you see there is a sclerosis present surrounded by lucency, and you know all this they produce sequestrum. So that's a sequestrum formed by E. coli, streptococcus, mycobacterium tuberculosis also will produce sequestrum. The one thing which is uncommonly seen is your Klebsiella. So usually we don't see Klebsiella associated with our bone infections. So the answer could be Klebsiella. So the answer what they've asked you is which is not likely. The question was which is not likely the diagnosis. Okay. Sorry, I forgot to add that, which is not likely. So diagnosis could be any of this. The most common organism would be, yes, Staph aureus. So the most common organism would be Staph aureus. Right. Mycobacterium tuberculosis also is associated with the osteomyelitis. No, it will produce the sequestrum and all. Okay, the Staph aureus is the most common one, you have to remember. And when it neonates, and if this question is given as in case of neonates, then you can think about streptococcus, right? Streptococcus, especially your group B streptococcus. So group B streptococcus are most commonly associated with the neonates. And one more interesting thing you have to remember, that is sickle cell anemia. So what is associated with the sickle cell anemia is your Salmonella typhi. Okay, sickle cell anemia is your Salmonella typhi. Okay, this is associated with your sickle cell anemia. So Salmonella typhi. And then your drug abusers. Okay. IV drug abusers. In case of your IV drug abusers, one which is associated is your which bacteria? Yes, it is your Pseudomonas. So Pseudomonas is associated with your IV drug abusers. Okay, and neonates is Streptococcus group B, sickle cell anemia Salmonella typhi, IV drug abusers is Pseudomonas. If they wanted to ask about, your tuberculosis, they can ask you that the cell mediated immunity. Right. So the difference between pyogenic and tuberculosis is, here it is cell mediated immunity, where there is a involvement of your T helper cells. Okay. So the lymphocytes play an important role in TB. So you have to be careful. So if there are something about pathology, it is lymphocytes. And when it comes to pyogenic, it is mainly the neutrophils. Okay, whenever there is an involvement of neutrophils, it is pyogenic. Involvement of cell mediated immunity that is mediated by TH cells, it is lymphocytes involved, it is Mycobacterium tuberculosis. But all this will produce what is called as sequestrum. And remember, certain bacteria which is involved in causing the osteomyelitis, like in IV drug abusers, it is Pseudomonas, sickle cell, it is Salmonella typhi, in neonates, it is Streptococcus group B, and rest of all, most commonly, this is what you have to remember, your Staph aureus. This is the most common. Okay, clear? Any doubts? Yes, Jayant, Abhishek, Arya, Swasan, all clear, everybody? Yes. Moving on to the next. Okay, all this has to be written on this, but I wrote here. Okay, now what you do, you will draw a particular tabular form and write all those. They have given it is leg is swollen and it is warm. They didn't give, see, cold abscess, Jayant, cold abscess also will be warm. But when you compare it with the pyogenic, it is not as warm as pyogenic, but still it is warm. Cold ka matlab nahi hai, ye pura, it is not completely cold. It is warm, but when you see the pyogenic, infections, it is very warm, it is hot actually. So this in MTB also, it is little bit warm only. Okay, I think that has cleared your answer, Jayant. Okay, so you have to remember that tuberculosis will present as sequestra also. And here there are types of sequestra, that also they might ask you. I will teach you that also. So here the sequestra is coarse, sandy, or feathery, or coke type. So all this is seen in your tuberculosis. This is the sequestra. And what is Jayant telling is exudative form of TB. You will see the cold abscess. So cold abscess is one where the pus is formed, but this is less warm. It is not actually cold, it is less warm. What do you mean means it is less warm. Still swelling will be present, it is less warm. Okay, so hence this is called as cold abscess. So TB ka features, you have to remember there is sequestra which is formed and this is exudative which is formed. And in sequestra also you remember in the TB, kissing sequestra. Kissing sequestra is seen in tuberculosis. Okay, and then rice bodies is seen in tuberculosis. So what are all this? So what happens in tuberculosis is, see, firstly I'll tell you, this is the joint and here this is your cartilage. Imagine this is your cartilage like this. So tuberculosis may what will happen is, the TB will come and will start the destruction from the periphery. So it will start from the periphery. So it will not go to the center suddenly. It will go to the periphery and then it will destroy all the subchondral bone and everything. So because it is on either side of the joint line, so here it is there, here it is there, hence this is called as kissing sequestra. So this is called as kissing sequestra, which is present on either side, which is present on the either side of your joint line. So this is called as the kissing sequestra. And then this articular cartilage damage, what is happening, will be present as the fibrinoid deposits. Fibrinoid deposits in the joint. So these are called as the rice bodies. So all these are features of your TB. So sequestra is formed. The sequestra is the coarse, sandy, feathery and coke type. And when it comes to pyogenic, the sequestra is usually tubular sequestra. It is usually tubular sequestra, right? So it is tubular sequestra and pyogenic. It could be coarse, sandy, feathery and coke in case of tuberculosis. You see kissing sequestra in TB, rice body appearance in case of tuberculosis, cold abscess in case of tuberculosis. It is less warm when compared to the pyogenic. So these are all the features of your tuberculosis, okay? And the bacterium, it is Mycobacterium tuberculosis. Yes. WHO recommended TB spine investigation of choice. So now we have dealt with the joint. Now most important is your TB spine. So in case of TB spine, this is also called as the Pott's spine. So this is also called as the Pott's spine. And the most common presentation of this is the paradiscal. The most common presentation of this is paradiscal. So why spine? It is mostly involved because there is hematogenous spread of Batson's plexus of veins. Batson's perivertebral plexus of veins. So this you have to remember. They might ask you. Okay. And then you see the dorsal vertebrae are the ones which are most commonly involved. Dorsal vertebrae or the DL, dorsal lumbar junction, and the most common one is your paradiscal. Right? Then what are the types? There is anterior, posterior and paradiscal. So these are the types. So anterior type of tuberculosis, posterior type of tuberculosis and paradiscal and central. So these are the types of tuberculosis, right? So the spread of the tuberculosis is always hematogeneous. So there will be some focus, and now the focus will shift to your spine by the arterial supply or your Batson perivertebral plexus of veins. And now what will happen? There will be destruction of the vertebrae. So this destruction of the vertebrae usually starts in the paradiscal level. So why paradiscal level? Because if you remember, the blood supply is like this. So because of the blood supply is to upper vertebrae, lower vertebrae, upper half, lower half and the disc. So this appearance is called as the spinal segment. Okay, this I'll draw it correctly. Are you guys following? So this lower half and upper half. So this upper half and this lower half is supplied by one vessel. So that is why this paradiscal is the most common one. Yes, the most common site for MSK is TB spine. What I have to rule out? Which question we have to rule out that? So here they clearly given pain of left leg, no? They have clearly given the here the thing as left leg, right? And in this also I have told you which is not likely, most likely, which is not most likely, right? So Ashutosh, are you talking about this question only? Which thing? So this is what? This is the TB spine, right? And now once the TB reaches your spine, it is very destructive. It will destroy entire vertebrae and the disc, and it will result in deformity. So these deformities as present as gibbous. So one vertebrae involved, it is knuckle. Two vertebrae involved, it is gibbous. Three or more, it is kyphosis. So these are all you can see in case of your TB spine, right? And TB spine, you have to be very careful about the red flag signs. So the red flag signs are what? The red flag signs are involvement of your neurological system. So whenever there is involvement of neurological system, that is deficits are present and your cauda equina syndrome is present, then you go for surgery. Otherwise, you can still try for your what? Conservative treatment. Now you can hear. So there was a mic issue. I've changed the mic. Now you can hear. Yes. Okay, fine. So now I've told you that you go for lab, then X-ray you see this so and so, and MRI you see the abscess formation, you see the level which is involved, and then now you go for, usually we used to go for biopsy to identify the condition of tuberculosis. But now recently what we are doing is, even though so there are certain criteria for the biopsy or whatever the test should be positive. So this much amount of tuberculous bacillus should be present so that it will tell you that the test is positive. But now with the help of PCR, even it is a minute level of bacilli which is present, we are making it into hundreds and thousands, and then we are identifying it. It is by your PCR technique. It is by your PCR technique, and now this technique is done using what? It is done using your CB-NAAT. CB-NAAT. So X-ray is not the diagnostic of choice, and culture and sensitivity takes a lot of time, and it is not usually recommended. CT scan may you can't diagnose infection directly. So CB-NAAT is the answer. So CB-NAAT is cartridge based nucleic acid amplification test. So you are amplifying the nucleic acid, that is whatever the RNA, DNA, whatever is present in the tuberculosis, you amplify it to multiple levels so that even the minute of it can also be caught. So that is called your CB-NAAT. Very, very important. It was asked recently. So there is heavy chance, there is high chances of it getting repeated in the NEET PG as well. So remember, the investigation of choice for tuberculosis now at present is your CB-NAAT, cartridge based nucleic acid amplification test. Okay, CB-NAAT. Clear? So this is about your TB spine and the investigation. So next, the female patient with rheumatoid arthritis has cervical pain, and this could be the answer. I mean, like, it is like most common cause. So usually I told you the commonly diagnosed, you will be commonly correct. If you do a rare diagnostic, for gold standard it is culture and sensitivity always, but for tuberculosis it is not culture and sensitivity, because tuberculosis will take lot of time. It will take like 20 weeks for the culture and sensitivity to come, the answer to come, you know, whether it is positive or negative. So the gold standard is not the culture and sensitivity, especially for bacilli, like especially for the bacteria like tuberculous bacteria. Okay, so here the biopsy still remains the gold standard, and CB-NAAT is now, you can quickly get the diagnosis, and it stands positive whenever even a small very, very sensitive, it is highly sensitive CB-NAAT is. Okay, and even it is specific also. Fine. Yes. So here the question is, a female patient with rheumatoid arthritis has cervical pain. What could be the most common cause? Okay. Whenever we are dealing with rheumatoid arthritis, as I've told you, it is a disease of the joints. So disease of the joints, why there will be involvement of multiple joints, especially the wrist joints, especially the MCP joints, the PIP joints. But it doesn't involve the spine. So spine it usually does not involve. But in the spine, most commonly what it does is it only involves the cervical spine. So there will be some problem only in the cervical spine. Otherwise, rheumatoid arthritis will not touch any other spine. It is only the cervical spine. All TB cultures, it is 20 weeks. 20 weeks, or it takes some 6 weeks or 8 weeks. Not sure about the weeks actually, but it takes a very long time. Yeah, TB culture is any TB culture, not only for TB spine. No, we are culturing Mycobacterium tuberculosis, right? So it is for the same. So probably it will take 8 weeks. Okay. You have to ask Anusha ma'am the answer for this. Okay. Fine. Okay, now what I was telling is the rheumatoid arthritis, right? So in the rheumatoid arthritis, what will happen is the spine is not actually involved. If the spine is involved, it is only the cervical spine symptoms we see in the rheumatoid arthritis, and specifically in the cervical spine, especially the joint between C1 and C2. C1 is called what? It is called the atlas, and C2 is called as the axis, right? So this Atlanto-Axial is what we see. So this between the joint between the C1 and C2 is what which is usually involved in case of your rheumatoid arthritis, and this is called as your Atlanto-Axial subluxation. It is called as Atlanto-Axial subluxation. This is one important thing you have to remember. It is not the cervical canal stenosis or the osteoarthritis or osteoporosis, which is usually seen. But what is more important is your Atlanto-Axial subluxation. Atlanto-Axial subluxation, and you have certain parameters which you have to remember. That is with the dens, what is the atlas which forms? So axis is one which is having the dens, right? So this interval, so what is the interval between atlas and the dens? That is called as anteriorly and posteriorly. So AD and PADI both has to be seen, and if it is more than 5 mm, it is normal. So 5 mm is the interval which has to be, and this has to be 13 mm. This is what you remember. So remember, rheumatoid arthritis mein what is the most commonly involved? Atlanto-Axial joint. So Atlanto-Axial joint subluxation is one which is usually seen in rheumatoid arthritis, and the parameters which tell you that it is subluxated or not is your atlas and dens interval. This is anteriorly and posterior atlanto-dens interval. So ADI and PADI. So this is, if it is more than 5 mm, it is good. If it is less than 5 mm means if the distance is decreased means there is subluxation. If it is maintaining 5 mm and 13 mm means it is normal. Okay, it should not go less than 5 mm. This should not go less than 13 mm. That is what you have to remember. Okay, and this PADI will also tell you the space present for your cord, right? Space available for cord. No, don't get confused between PADI and SAC. SAC and PADI are the same, which is SAC means space available for the cord. So it should be minimum of 13 mm. If it is less than 13 mm, there is some problem with the C1 and C2. That means there is some subluxation happening in between. Okay, is that clear? Yes. Yes. Now, next question. You have to go a little fast, okay? During walking, the hip bone on the side of the suspended leg is raised, okay, by the action of which muscle present in the supporting leg? Okay, now the question here, they are mostly asking you to test the knowledge of the hip biomechanics. So, hip biomechanics is one more interesting thing, which is a result of your Trendelenburg. So, I hope you have earned what is Trendelenburg test. So here this will test your what? Trendelenburg test is mainly to tell you what about your hip abductors. So hip abductors is one of the most important things you have to remember whenever it comes to hip biomechanics. So there are two types of abductors we have. One is gluteus medius and the second one is gluteus minimus. Medius and minimus both are supplied by which nerve? Which nerve supplies this? It is the, yes, anatomy integrated. They will ask you which nerve supplies this gluteus medius and gluteus minimus. Okay, the answer is A, but I am asking you which nerve supplies. Okay, now you see the Trendelenburg test is mainly depending upon the hip biomechanics. So whenever you stand on your 2 feet, so this is called as stance phase. So now I am standing on my 2 feet, so all my muscles are intact. Now if I want to stand on a single stance, so if I want to stand on a single leg, so this leg I am standing. So this leg I am standing. So this leg I am standing on, and now if you see, if I am standing on this particular limb, okay, so when we stand on the 2 feet, 2 feet we are standing. If you see both the hip levels, so where do you see the hip level? You see at the posterior superior iliac spine, so PSIS. So this is your posterior superior iliac spine. So both, if you're standing on the 2 feet correctly, both will be at the same level, which is normal. And now if you stand on a single stance also, now for example, think you're standing on the right limb completely and left limb is up, okay, raised. So right limb it is raised, and still you can see the both are maintained. Even though the left limb is raised up, standing only on the one limb, still it is maintaining. But what usually should happen? It usually should happen either it should go up or it should go down. Right, it is not normally maintained. So if you stand on single leg, usually we tend to do like this or we tend to do like this, but still we are able to stand on a single leg stable because of the pull or action of the abductor muscle. So pull or action of the abductor muscle. So these muscles, so when you stand like this, usually the so if you're standing on the right limb, usually the left limb try to go up like that. Okay, it will go up like that. So we are pulling it to normal. It is by the action of the abductors which are present on the right side. So this right action of the abductors will pull this to normal. Now if these abductors are weak, so they are not able to pull this. So hence you will see the dip. So dip is present still in the left limb because of the right abductors. Get that? So this is your Trendelenburg sign. So this is your Trendelenburg sign. So you understood? Everybody, you understood? Yeah, we'll decide whether it is a superior gluteal nerve or inferior gluteal nerve, but first you understand this. This is important for me. That is important for anatomy, okay? So here what is happening? So here what I'm trying to tell you is when you're standing on the two limbs, you see that there are two limbs, the PSIS is maintained at the same level. But if the patient is standing to try to stand on one limb, this is called the single stance. So this is called as a single stance. Matlab he is trying to maintain on the one limb. So single stance is one limb, right? And the other one is in air. Right. So what is happening? Still it is maintaining at the same level. Why it is maintaining? Because the right abductors are active and pulling it toward the same level. Okay. So if you try to stand like this, you can go this way, whichever way you want, you can go because there is no support. Right. So by this right abductors are trying to pull and they are making it stable. But if this right abductors are absent or if there is a weakness of the right abductors, okay, what will happen? You can see there is a dip in the opposite side. So dip in the opposite hip. So this here the dip is seen on the left hip. So they might ask you if there is a dip in the left hip, which muscles are not working. So the muscles which are not working are the right abductors. Yeah, you see the lurch on the same side. Yes, the lurch is nothing but now the trunk will try to compensate the dip. So because of the trunk is trying to compensate the dip, we trying to tend this side. So that is called the lurch to the same side and pelvic dip is seen on the opposite side. Okay, is that clear? Okay, now what is the answer for this? So in this gluteus medius or minimus, which is more active? So gluteus medius is one which is responsible for this support. Okay, so this supporting leg which is trying to pull is the gluteus medius. So between medius and minimus, the medius is more active. So it is the gluteus medius. So this medius is and minimus are called the abductors. Okay, fine. Next. So what is the full form of FRAX? So this was a direct question which was asked again. What is the full form of FRAX? Is it fracture risk assessment or it is fracture rehabilitation assessment, fracture repair assessment or fracture reduction assessment? Yes, so this is a direct INICET PYQ. What is a FRAX? So FRAX is nothing but it is a scoring system. So you already know that in case of your osteoporosis, so whenever we deal with osteoporosis, so there is a deficiency of the bone mineral density, and this we diagnose based upon your DEXA scan, right? So we use what is called as the DEXA scan for diagnosing of your BMD. But here they have come with a scoring system where you diagnose the probability of the fracture. So you take in account the probability of the fractures that will happen in the next 10 years. So they will tell you that how much probability, how much percentage there is chance that you can end up with the fractures in the next 10 years basing upon this scoring system. So this is the scoring system they use, developed in UK. So there are questions which have been asked. So they will ask about the age, the sex, the weight, height, previous history of fractures, your parent histories of fractures, usage of any corticosteroids, your smoking, alcohol, your BMD, presence of any rheumatoid arthritis or any femoral presence of any secondary osteoporosis, all those things are taken into consideration. So this was asked in the next INICET, that what are all the things which have been considered. So remember the age. So age is considered, that is the parameters of age, sex, weight and height, that is calculating your BMI. Then they will test the glucose corticosteroids usage, then your alcohol and smoking, right, and any risk for secondary osteoporosis you have, and your parent history for fractures or any fractures history yourself, so fragility fractures history and BMD. So all these are calculated, and now they will tell you whether you are at a risk of having the probability of having the fractures in the next 10 years. It is called fracture risk assessment. Okay. So the answer is, it will test your fracture risk assessment. Okay. It is a fracture risk assessment score. This is called as the FRAX. Okay, fine. So this is your FRAX, and it is a software. So you have to just give the inputs, and it will select and it will calculate and give you the answer. Next. So now I think you have to answer this, because we had a great detail about what are all this. So what is the intracapsular fracture of 40 years old? What is the answer? The intracapsular fracture of the 40 years old. Treatment. So here I am asking you about the treatment. Yes, because we have discussed already. So is it ORIF, CRIF, hemiarthroplasty or total hip replacement? Yes, what could be the treatment? So here ORIF is open reduction and internal fixation, CRIF is closed reduction and internal fixation, hemiarthroplasty and THR. So I will make you easy. So 40 years, so you will not have hemi or you will not have THR. Then what you have? You will have ORIF or you will have CRIF. So now here again they are testing you the knowledge of what is an internal fixation. So definitely not hemiarthroplasty, because the age is 40 years. I told you whenever the age is less than 50 years, what we give? We go for osteosynthesis. Please don't forget. So whenever the age is less than 50, we have to think about osteosynthesis. That is, we have to think about uniting the fracture. So uniting the fracture. Okay, so how do you unite the fracture? How do you fix the fracture? So fixations of fracture can be of two types. So one is called ORIF, the second one is called the CRIF. So fracture fixation can be done using two ways. One is open reduction, internal fixation. The second one is closed reduction, internal fixation. So what do you mean by open reduction? That means you open the fracture, right? So open the fracture completely and then you fix it. So what do you mean by CRIF? CRIF is closed reduction. So you don't open the fracture, you reduce the fracture with the help of your C-arm, that is your fluoroscopy. So you use fluoroscopy to reduce the fracture and then you fix it. Okay, and then you fix it. So now what you do for this? You do either a ORIF or a CRIF. You do a open reduction or a closed reduction. So open reduction is usually done for both bones forearm. So if the both bones forearm there is a fracture, so we go for open reduction, because we have to see the fracture properly and reduce the fracture completely and then fix it, because it is treated as a periarticular fracture. So whenever we are dealing with the periarticular fracture, that means any fractures which are occurring around the joint. So you have to go for an ORIF, because you have to get an anatomical reduction of that particular fracture and then you fix it. If somewhere you are dealing with the shaft, so then you can go for a closed reduction, because this reduction you can do it by the help of your fluoroscopy. Seeing under the fluoroscopy, you can reduce the fracture and then fix it. When it is coming to the IC fracture, what I told you in IC fracture, we do what is called as the CC screws fixation, right? So CC screws fixation what we do is we do this under fluoroscopy. So that means, what is this? So this is a type of CRIF. That means we do close reduction and internal fixation. So this internal fixation is done with what? We done with the cancellous screw. So we do this fixation with the CC screws. Okay, so this is a type of CRIF, that is close reduction and internal fixation, and this fixation is done with the help of cannulated cancellous screws. Okay, and I told you that these screws are half threaded screws and this thread has to cross the fracture. That means if there is a fracture in this particular, so if this is the fracture, and now you are trying to put the screws like this, right? So you are trying to put the screws, and this screws you put it like this, and here is the fracture. So this fracture, the screws which are present, the threads has to sit onto the head. So this thread has to cross the fracture. So we put 3 screws like this. And on the lateral view, you will able to see that we are putting in the inverted triangle fashion. So this is the AP view, this is the lateral view. On the lateral view, you see that is the inverted triangle fashion. We'll try to put these screws. So this is a case of CRIF, that is close reduction internal fixation. Okay, is that clear? Yes? Any doubts? Okay. Now next one, injury to the posterior interosseous nerve leads to. So what is a posterior interosseous nerve? So posterior interosseous nerve is a branch of, so it is called as pin, and this is a branch of what? This is a branch of your radial nerve, and you have to remember that this is a purely motor nerve, and here the pin is also purely motor. And if you get back to radial nerve, it supplies what? This radial nerve supplies all the extensors. So median nerve supplies all the flexors, radial nerve supplies all the extensors, right? And these extensors are present in 6 compartments, right? So they are present in the 6 compartments. And this radial nerve will give a branch which is called as the pin. So this radial nerve branches which is called as the pin, and now this supplies all the extensor which are supplied to the fingers. So the long extensor especially which is, you know, supplying the wrist. So the wrist joint is by your 2 ES extensor carpi radialis brevis and extensor carpi radialis longus. So these are ERCL and ERCB are one which are mainly associated with the wrist joint. So there is no wrist drop if the pin is injured, right? So wrist is normal, but what will happen? They will be fingers drop. So the finger drop will happen. So there is a loss of extension of the fingers. So there is a loss of extension of the digits. So supination will not be, loss of extension, supination, the loss will not be there because it is by musculocutaneous nerve. And then wrist drop is mainly by the injury to the radial nerve. So wrist drop and extension of the wrist is the same, right? So by elimination, we have eliminated the 3 and left out with the loss of extensors of the digits. So extensions of the fingers is not seen, and this is called as the finger drop. This is called as the finger drop. Clear? Yes? Next. Okay, 35-year-old with back pain, stiffness, uveitis, imaging suggesting of sacroiliitis. Which of the following HLA is commonly associated? So this is again one of the favorite, most important question usually asked in various competitive exams. And here they have clearly given you that there is a back pain, there is a stiffness, and to your conclusion, they also told you that this is sacroiliitis. So whenever you see this condition associated with the sacroiliitis, so what is the first thing which strikes your mind? It is ankylosing spondylitis. So ankylosing spondylitis is a condition. Usually it is again an autoimmune, right? So this is, what is this? This is mostly seen in case of males, and this is usually seen in case of your axial skeleton. So axial skeleton is involved, and most important thing is you have to see the sacroiliitis involvement. So the involvement of the sacroiliitis is very, very important to diagnose it as ankylosing spondylitis. Okay, and what is the other things we see? You see again as other inflammatory arthritis. This is also the patient presents with stiffness. Patient presents with morning stiffness, and this morning stiffness is mainly the low back ache. So the morning stiffness is mainly the lower back ache, right? So lower back ache the patient presents with, and it gets normal with the activity. And then enthesitis. The one more important thing you have to remember is enthesitis. That means the tendons and the ligaments. So the patient will have heel pain. So enthesitis is nothing but attachment of tendon to the bone. So whenever the tendon is attached to the bone, that is called the enthesis. So whenever that is inflamed, it is called as enthesitis, and here the patient presents with heel pain. And other systems are also involved, especially the uveitis. So patient usually with ankylosing spondylitis present with other systemic features such as uveitis or cardiovascular, and not to forget your pulmonary symptoms. So the chest circumference also will decrease. So he will have shortness of breath, he will have recurrent uveitis, and some cardiovascular abnormalities also will be present. Okay, and now you see here, these are the signs which you see. So the first most important one is the X-ray which we take, and on the X-ray we see the SI joint. On the X-ray we see this is the SI joint, and in this SI joint usually what you see is the haziness. You see the haziness of the SI joint. So this is the haziness of the SI joint we see. So that is very, very important. So sacroiliitis should be present. And then what you see the presence of the bamboo spine. Before that, what is this? What is this called? It is called as the dagger sign. So dagger sign is nothing but there is a calcification of the ligaments. So whenever this posterior longitudinal ligament is calcified, okay, whenever this is calcified, so this is presenting as your dagger sign. Okay, so all these spines, they produce syndesmophytes. So what is this? Not the osteophytes but the syndesmophytes. So what do you mean by syndesmophytes? Syndesmophyte is which is associated with each other, right? So now all this resulting in formation of your bamboo spine. So this syndesmophytes will result in what is called as the bamboo spine. Okay, so what is actually happening in bamboo spine? So the patient will have restriction of the flexion. So the patient cannot bend. So there will be restriction of the flexion. So that is why bamboo spine on all these osteophytes are called syndesmophytes. And sometimes you see what is called as the squaring of the vertebra. So this is mainly your squaring of the vertebra. Okay, this is also clearly seen in your ankylosing spondylitis. So squaring of the vertebra, syndesmophyte, the dagger sign, your bamboo spine, all these are features of your ankylosing spondylitis. Okay. So now what is the important thing what they have asked? They are associated with the HLA-B27. So they are associated with your HLA-B27. So the answer is HLA-B27, right? So the answer here is HLA-B27. Okay. HLA-DR3, DR4, B1, you should answer. You mean you are better than me, right? You keep reading all the 19 subjects. So I am only associated with the ankylosing spondylitis. So the answer here is HLA-B27. Squaring is also seen in osteoporosis. So osteoporosis, what we usually see is the wedging. Instead of squaring, what we usually see is the wedging. Squaring sometimes can be seen in Paget's disease, like your picture frame vertebra. So usually in the osteoporosis, what we usually see is the wedging, not exactly squaring. But in Paget's disease, some amount of squaring you can see, like your sclerotic in square shape, which is called as the picture frame vertebrae. Fine, clear? So ankylosing spondylitis is very, very important. They'll tell you that the patient will have heel pain. They'll tell you the patient will have uveitis, pulmonary complications, and now he will tell morning stiffness and all, and especially in young males. So you have to remember that young males are the ones which are affected here because of the genetic factors, that is HLA-B27. But females also you can see this. Okay. Yes. Sequestrum is a piece of dead bone that has become separated from the process during necrosis from the normal bone or the sound bone. Ring sequestrum is seen in which of the following conditions? So they have given you the whole definition of sequestrum to ask about what is ring sequestrum. That is how, you know, they are framing the questions, making it big. Right. So here you already know that the sequestrum is nothing but, we have seen that tubular form of sequestrum is seen in the pyogenic infection. So whenever it comes to tubular, it is pyogenic infections. I'll just see the slide. Then this is the pyogenic infections, right? And whenever you see this is coarse sandy. So coarse sandy type, coke type, or feathery sequestrum? So, what is the answer? Answer here would be your tuberculosis, right? And now the type of sequestrum, what you see, ring type of sequestrum is mainly seen in your external fixation. So, external fixation and your amputation, right? And amputation. Okay. So, this you have to remember. And when it comes to coke or black color sequestrum, it is seen in actinomycosis, right? Coralliform sequestrum, it is seen in Perthes disease. Okay, and then you have your fine sandy. Coarse sandy is TB. Fine sandy you see in your viral osteomyelitis, right? So these are types of sequestrum, and I've given you the table form here. Don't worry. So here these are the tabular form, and ivory sequestrum is seen in syphilis. Syphilis, you also remember that there is an ivory type of sequestrum which is seen in syphilis, and black is actinomycosis and fine sandy. So sandy is two types, coarse sand and fine sand. So if it is fine sand, remember it is the viral osteomyelitis. So usually in case of your viral osteomyelitis, you see the fine sand, and coarse sand is tuberculosis, feathery is tuberculosis, coke is tuberculosis. Okay, fine. So that is about the answer. So the answer here remains as infection at the pinhole of external fixator. So this is the answer. So the answer is this. Okay, after radiation, what type of sequestrum you see? After radiation, you see what is called as buttonhole sequestrum. Here you see it is the buttonhole sequestrum. Okay, and salmonella, it is the mainly seen in case of sickle cell anemia. There is not specific sequestrum which is seen. In TB infection, I have told you the coarse sandy, coke and feathery infections in sequestrum we see. Okay, clear guys? Yes. So these are the types of sequestrum, and you know what is sequestrum, what is involucrum, what is cloacae. Very, very important. They might ask you. And infections are of two types. We have already discussed much about acute, and then we have discussed about chronic, and there is one more that is subacute. So subacute you have two. One is Gary's sclerosing osteomyelitis, where you see there is lot of sclerosis which is involved. Okay, and the second one is your Brody's abscess. So Brody's abscess is the lucency. So this is seen as sclerosis. This is one is seen as lucency as a cavity. Okay, localized cavity. Then what is sequestrum? Sequestrum is nothing but a dead piece. So this dead piece is formed as a result of decrease in the avascular necrosis. So there is a decrease in the vascular supply, right? So because of the vascular supply is decreased. Why the vascular supply is decreased? Because of the infection. So this infection will cause micro abscess. Abscess is nothing but pus. So this will increase the pressure and will decrease the blood supply and result in a dead piece of bone. So this dead piece of bone is on the X-ray seen as the highly sclerotic. So this is the dead bone. So anything which is dead is seen as sclerotic on X-ray. Why? Because there is no vascular supply. So bone has to be, bone is a dynamic tissue, right? It has both absorption and resorption. So whenever there is no resorption on the bone, it will appear as sclerotic. Why there is no resorption? Because there is no vascular supply. So this dead bone which is white and which is dense and sclerotic. So these are all the terminology which you can use for the sequestrum. So it is white, dense and sclerotic, and it is surrounded by lucency. This you should not forget. So this sequestrum is always surrounded by a lucency. So this lucency is nothing but your granulation tissue. So this lucency is nothing but your granulation tissue, right? And then you see a thick reactive bone. So when you see a thick reactive bone, this is called as your involucrum. So this is a thick reactive bone which is formed. This is called as involucrum. So you can see sequestrum, lucency and thick bone which is called as involucrum. So these are the components of your chronic osteomyelitis. And what are the openings? Openings on the involucrum, this is called as the cloacae. So the openings on the involucrum is called as the cloacae. Okay, yes, clear? Yes, and now this involucrum opening, there will be discharging sinuses, and this discharging sinuses will produce what? Bony spicules. So discharge bony spicules. So these bony spicules discharging is the characteristic feature of your chronic osteomyelitis, and on the X-ray you see all these features. Yes, this is a straightforward question. Which of the following is this particular brace? Is it a Boston, Milwaukee, Taylor's, Ash? Yes, quickly. So the answer we wrote here, no, it is, this is the answer, right? And buttonhole sequestrum you see after radiation. So which type of brace is this? Yes. Which type of brace is this? Is this the Milwaukee brace or a Boston brace or a Taylor's brace or a Ash brace? So what is the Ash brace? Ash is an anterior hyperextension. Anterior spinal hyperextension. Okay, so it will prevent hyperextension, right? So this is not your Ash brace. Okay, it is present on the anterior aspect. Taylor's, I told you, it is mainly used for TB and it is usually for the DL orthosis. That means it is the dorsolumbar orthosis. And Boston is mainly again for your thoracic orthosis. So thoracic, and it is mainly present at from the thoracic level, right? From the sternum to the DL junction. Okay, so that is your Boston brace. So whenever this brace is extending up up to the occiput here, supporting your mandible, so this is what is called as the Milwaukee brace. Sorry, Boston is thoracic. So this is called as the Milwaukee brace. So the answer here, it is the Milwaukee brace. So what is a Milwaukee brace? Milwaukee brace is something which is used for scoliosis. So this is the answer, and this is your Milwaukee brace where it is used for scoliosis, supporting your occiput at the back and your mandible, the chin in the front. Right, so it acts orthosis for your cervical and your thoracic, right? Cervical and thoracic. What is the Boston brace? Boston is mainly for thoracic. So it is present as a compartment. Boston is present as a thick compartment extending only up to this level. Okay, from here to here. This is your Boston brace. So if you see something only like below the shoulder level, so that is your Boston's brace. Okay, but if it is extending up to the high occiput and supporting your chin, then that is your Milwaukee brace. Yes, the answer is the Milwaukee brace. Okay, next. Best results after meniscal repair is seen in repair of red zone, white zone, gray zone or red white zone. So what could be the answer of this? So for this you have to understand that there is meniscus on both the sides of the condyles, right? So this is your meniscus, and you know this meniscus are nothing but they act as cushioning substance, right? So they act as cushioning substances on the tibial condyle. So this is your tibial condyle, right? So this is your tibial condyle. Okay, and now what happens is this is acting as cushioning, and this meniscal will give you a what you give, they are devoid of vascularity, so they only take the nutrients from the surrounding structures, and now this cartilage is mainly for the cushioning effect, like it will prevent the friction between the two surfaces. It will prevent the friction between the two surfaces. So whenever there is a problem in this, so this regeneration of the cartilage is divided into three types. So here it is the inner side, which is called as the white zone. So the inner side is called the white zone, and the outer side, so the blood supply is from outside to inside. So the outer side, this side is called the red zone, and this is called as the red white zone. So this is called as the red white zone, right? So this supply, this outer one, this is called as the red zone. Red zone matlab RR zone. So it is rich in blood supply. So whenever there is a tear in this RR zone, that is red zone, what you do is you repair it, right? So whenever you repair, it will heal. So there is a healing potential which is present in the red zone because of again your blood supply. So it is rich in blood supply, the outer aspect of the meniscus. But when you go to the inside, this is called as the white zone. So this white zone which is there, it is not devoid, it is not, white zone is white because no blood supply. So here whenever you find the tears of the meniscal, what you do is you remove the meniscus, right? So you remove the meniscus, which is called as meniscectomy. So removing of the meniscus. Okay, so remove in the white zone, repair in the red zone. So healing potential is high in the red zone and healing potential is less in the white zone. So remember RR, red zone is where the healing is better. Very good. Okay, so the answer here is the red zone. So there is a red zone which is present, and here the red zone is the one where the healing is maximum. Healing is maximum. Okay, healing is maximum, and here you will encourage repair of the meniscus. You will encourage the repair of the meniscus. When it is white zone, you will remove. So this is called as meniscectomy. There is no gray zone. Okay. So there is no gray zone, and this gray zone is nothing but your red white zone. It depends. It depends whether it's towards the right zone or towards the white zone. Okay. So the answer here is the red zone. Answer here is your red zone. Okay, is that clear? Kajal Sahu, yeah. We keep sending the notes now. What is the problem? There is no problem. Every notes will be updated. They will be there. Maybe it will take some 1 or 2 days, but every notes will be available right there in the app or maybe the group. So they will give you specific instructions and you're supposed to follow this instruction to get the notes. Okay. Right, then what is the answer for this? Which of the following ligaments? This is also a direct INICET question. So, which of the following ligaments is injured in the image? If you see the image, this is the image of the shoulder joint and you can label it, this is the humeral head. So, this is the head, right? And then you can see this is your clavicle and this is your acromion and this is your coracoid. Right. So, all these structures and you see this is clavicle and acromion. If you actually see the normal X-ray, you will see that these two are together. So, here what happened, there is an acromioclavicular displacement. So, there is a displacement between acromial and clavicle and this is because of the ligament injury. So, this is because of the ligament injury. So, what are the ligaments which are present in this particular area? One is called the coracoclavicular ligaments and then you call the acromioclavicular ligaments. Right, so these two are very, very important, the coracoclavicular and the acromioclavicular, and here this is because of the acromioclavicular. So the ligaments which are injured here is your acromioclavicular ligament. Okay, AC ligaments. Coracoacromial nahi, coracoclavicular, CC. So you will have ligaments like this which are injured and you will have ligaments like this which are injured. There are no coracoacromial ligaments, right? Okay, so the answer here is acromioclavicular ligament. So because of the acromioclavicular ligaments which has got injured, so there is a displacement in the acromioclavicular joint there. So you can see the clavicle is elevated up. Why it is elevated up? This is because of pull of the sternocleidomastoid. We have an official group for everything, right? We have Telegram official group for which where there is an INICET PW Minute official group is there. I will ask the team to pin it up after the session. Okay, you can join the official group later. So this is the AC joint which is there. So here what will happen? So here what is the problem here? So because the sternocleidomastoid muscle is attached to the clavicle which is pulling up. And how do you identify the injury of the AC joint? Adduction. So you are trying to do cross adduction like this. You are crossing the your arms opposite way and here you will have pain. So whenever they are not able to do adduction, okay, and whenever they are not able to cross, then you will have pain in the shoulder. That is because of your AC joint disruption. So this is your acromioclavicular disruption where the ligaments between your acromion and clavicle and the coracoid are disrupted and this will result in AC joint displacement. Right. So AC joint is the only joint which helps you suspend the limb, right? So that is why whenever there is a damage to this AC joint, you will have pain in the shoulder doing the activities. So how do you test the activities? You do adduction test. So adduction test is you're trying to cross the arms and whenever the patient is having pain in the shoulder joint, that is indication of your AC joint disruption. Okay, so the question which was asked is what ligaments were disrupted? So the answer is acromioclavicular ligaments, acromioclavicular joints. Okay. Yes, next. This is very important and I hope you will all will answer it. So, a 35-year-old female presents to the emergency after a fall in the bathroom 20 minutes ago. She is vitally stable. On examination, you will see this hand deformity and I'll tell you this is the dinner fork deformity which is seen on the image. So, if the image is not clear, I'm telling you that this is the dinner fork deformity. So, now tell me what is the dinner fork deformity in terminology, in words. Okay, so whether it is an intra-articular fracture or extra-articular fracture or extra-articular fracture with the dorsal or volar or a Box's fracture. So what is the name given to this particular dinner fork deformity whenever you see the fracture? Yes, what is a Colles fracture according to this? Is it A, B, C or D? Yes, we all know it is a Colles fracture, but you have to know the concept. So INICET is testing the depth of the knowledge. If you see, everybody can answer that it is an Colles fracture. Everybody can answer that this is at the fracture of the wrist. Everybody can answer that it is a somewhat extra-articular fracture. And now it comes whether this is a dorsal displacement or a volar displacement. So understanding the depth of the concept is what is required, right? So here, Srish has answered that it is an extra-articular fracture at the wrist with dorsal displacement. So whenever we are dealing with the wrist fractures, so wrist fractures, what you will see is, so there is a fracture and you have to see whether it is an extra-articular fracture or an intra-articular fracture, right? So if it is an intra-articular fracture, again in the intra-articular fracture also you have two, dorsal, volar. Okay, but the name given to this particular intra-articular fracture is called as the Barton's fracture. So whenever there is an intra-articular component, so you name this as the Barton's fracture. Okay, and now coming to the extra-articular fractures of the wrist, there again depends upon the displacements. So one is called the dorsal displacement, the second one is called the volar displacement. So dorsal displacement with extra-articular fracture, this extra-articular at the level of corticocancellous junction. So this is at the corticocancellous junction. So this is called as the Colles fracture. Okay, similar fracture with the volar displacement, this is called as the Smith fracture. So this is called as the Smith fracture. So reverse Colles fracture or the Smith fracture. But whenever it is intra-articular fracture, it is Barton's. Very good. So intra-articular it is Barton, extra-articular it might be Colles or Smith depending upon the displacement. Whenever it is a dorsal displacement, it is the dinner fork deformity. So the answer here is the dorsal displacement. So whenever it is a volar displacement, it is a garden spade deformity. It is a garden spade deformity. Okay, remember the deformities are very important. Garden spade deformity, Colles volar. Okay, that means reverse Colles volar. Or dinner fork deformity is Colles with the dorsal displacement. And your gun stroke deformity is at the elbow, which is called as cubitus varus. Okay, that is the deformity. And genu varus deformity is in the knees, usually seen in rickets. Okay, knock knees is genu valgum. And again, you will see in case of your rickets. Okay, so these are certain deformities which you have to remember. Fine? Yes. The most common pattern of involvement of sports spine. So some of these important like this, direct questions which you can't leave. So that is why I have made an attempt to put these type of questions also, because sometimes we feel these are very easy questions and we try to neglect or we try to overthink that something else they are asking because it is very easy. So they have just asked what is the most common pattern of involvement in the Pott's spine, and the answer is so as simple as this. As we have already discussed the Pott spine, can somebody answer what is the answer? Yes, the answer is the paradiscal. So why it is paradiscal? So because of the spinal segment. We have already discussed that two vertebrae are present and this vertebrae in between have the disc. So how is the blood supply to this particular thing? So the blood supply is upper half, lower half. So because of the blood supply in this particular area, so there is a plexus which is happening here and the bacteria is present here, so which will result in the most common type of presentation of TB spine, which is called as paradiscal type. And there are other types, that is central, posterior and anterior. Okay, understood? Yes. Okay, coming to the end of the topic. So what is this? Without this, we can't close, right? Any competitive exam, we can't close. 35-year-old man presented with the knee pain, X-ray showing so-and-so features. What is this? It is a chondroblastoma, it is a costochondroma, osteoclastoma, fibrous dysplasia. So the answer here, this I think everybody can answer really well. So here you see what is the type you can see. So here you can see that it is involving the epiphysis. So whenever you want to answer a tumor question, first you have to locate the bone. Then you see what is the tumor doing to the bone, right? So what is the tumor doing to the bone? It is presenting with the lucency, right? So it is presenting with the lucency, and you can see that there is a soap bubble appearance. So it is a cluster of lucencies which appears as soap bubble appearance, and you can see it is seen after skeletal maturity. So age is again very important criteria. It is more than 20 years of age in the skeletal maturity. The thing which we see on the epiphysis, where you see the lucency, it should inevitably be the osteoclastoma. So the answer here is your giant cell tumor, the osteoclastoma, right? Is that clear? Very good. Next, what is chondroblastoma? Chondroblastoma, mind you, it is also seen in the epiphysis only. So chondroblastoma is also seen in the epiphysis, but here what you see, the cartilage component you see, the cartilage component you see. Whenever you want to see the cartilage, it is either the popcorn calcification. So cartilage is usually seen in form of calcification, right? So that is why you have to be very, very careful whenever you are doing a tumor question. So you have to see whether it is in the epiphysis or meta or dia. In the epiphysis, be careful whether it is chondroblastoma or osteoclastoma. So here we are very secured and happy because clearly it is showing that there is a cartilage which is seen, and clearly it is a skeletally matured patient, so it is a GCT. So chondroblastoma is usually the cartilage, and it is seen in the children, and here whenever you want to tell that is a cartilage tumor, there will be calcifications like your popcorn calcifications, your comma shaped calcification. So be very careful. And then what is osteochondroma? We have discussed, it is nothing but exostosis, and this is usually seen in the metaphysis. So this is usually seen in the metaphysis, right? So in the metaphysis you see the extra growth which is away from the joint. So this extra growth will be away from the joint, right? Okay, so this is your osteochondroma. And fibrous dysplasia is seen again in the diaphysis or the metaphysis. So here what you see is the deformity. So diaphysis or metaphysis, you see the deformity, the shepherd crook deformity, and the bone is completely filled with the fibrous tissue. So there is a change in the bone itself. So the bone will be changed. So the architecture of the bone is completely changed. So yeah, it is also called as exostosis. Very good. So here the answer is GCT, your osteoclastoma. Very, very important question. It will ask in multiple ways. Whatever they want, they will ask. What is the treatment? So here you have to remember, they might ask you what is the treatment to it. So the treatment which includes, it is an extended curettage. So whenever you see a GCT, it is an extended curettage is the treatment. That means you will remove the cavity. So it is a cavity with a curette. So there is a curette, you remove, and after removing you will add some adjuvants like liquid nitrogen or your bone cement. So these are the adjuvants which we add so that the recurrence is not there. Okay, so that is why we call this as extended curettage. Okay, and now recently the drug which is involved in treating this is your denosumab. This is also you have to remember. So denosumab is the drug which is being recently given to the patient of GCT so that it will mediate the rank and rank L pathway, right? And this will decrease the tumor. So they will decrease the tumor size so that surgery will become easy. Okay, so remember this they might ask because this is a recent advancement again. So denosumab is being given. Yes, the shepherd crook deformity is seen in fibrous dysplasia, correct. So in case of GCT, remember all these questions which they might ask, the treatment extended curettage or what is the recent advancement in treatment of GCT. They are using the denosumab as a treatment prior to the surgery to decrease the cavity size. Next, combination of appearance in the CTEV. So we have already dealt what is CTEV. We know there are the series of deformities and what is CAVE. So there is equinus, eversion, forefoot adduction. So there is no eversion. This is wrong. There is equinus, eversion, adduction, cavus. So this is the right answer. And there is no abduction wrong. And the equinus inversion, there is no planus. So the answer is B. Straightforward answer. So cavus, it is. So this question, if you see, this particular question was asked somewhere in 2020 maybe. And again, now you see in 2025, they have asked the same question but with the change. So they have put what is equinus, what is cavus, what is planus, what is calcaneus. So similarly, the topics will be the same. The questions will be the same. The terminology will differ. Okay, the same question you see. This is the what was asked in 2020 or 2021. I don't remember exactly, but what that was recent 2025, November 2025. The first question what we have dealt, that is the planus, cavers, that question they have asked. Okay, so this is how they usually ask. Okay, 60-year-old patient presented with limping gait and left hip pain. What is the likely diagnosis? So, you know, there is a patient, 60-year-old patient, and now he presents with limping gait. So, there is a problem with the muscles. So, there is a gait, and there is a problem with hip joint, and there is a pain in the left hip pain, and there is a X-ray. So, if you see this particular X-ray, this is not ankylosing spondylitis because they have not mentioned anything about the spine. This could not be, again, okay, 2 times they have mentioned ankylosing spondylitis. Okay, we'll remove the 2. Either it could be, okay, let us put this as osteoarthritis of hip. Okay, so whether it is an tuberculosis of hip, osteoarthritis of hip, or avascular necrosis of hip. So what is your answer? Yes, what is your answer for this? So here I want to tell you some important points in favor of this X-ray. You see in this X-ray you will find there is a subchondral cyst which is present here. Right, and if it is osteoarthritis, if it was osteoarthritis, the disease will start in the joint space. So the disease will start in the joint. Here the joint space is still maintained. So you can see the joint space is still maintained here. And if it is a tuberculosis of hip, there will be trabeculations loss. So there will be loss of trabeculations. Okay, and there will be deformity more. Okay, in case of your tuberculosis of hip. But here what you see is the subchondral cyst. So there is some, you know, discomfort in the, some disruption in the head of the femur. And you see the cyst, and whenever you see the cyst, the subchondral cyst and involvement of the femur head, it is mainly your avascular necrosis. So the answer is your avascular necrosis, right? You people are answering as tuberculosis of hip. No, hip usually again will involve the joint space. So hip usually, tuberculosis will usually start in the acetabulum. Okay, the roof of the acetabulum is the one which usually gets involved first. So again, there will be decreased joint space. There will be regional osteoporosis. So here what you see, here you see in the avascular necrosis, what you see is sclerosis. Okay, so tuberculosis of hip, what you see the osteoporosis, right? So it should be osteoporosis, but here what you see a lot of sclerotic bone and with the subchondral cyst. So the answer here is your avascular necrosis. Debankita Das, are you answering this as B, tuberculosis of hip, or the previous question? Okay, if this is the, you are answering this as tuberculosis of hip, no, it is not. It is avascular necrosis. So what is avascular necrosis? Avascular necrosis is a condition where there will be disruption of the vascular supply to the femoral head. This disruption could be because of some of reasons such as the most common reason is idiopathic. So little thing about avascular necrosis of hip, this is also important topic. So avascular necrosis of the hip is nothing but decrease in the vascular supply. So this is the sole purpose, the sole cause of avascular necrosis is decrease in vascular supply. But why decrease in the vascular supply? Their factors can be multiple. So the first and foremost is it is mainly because of idiopathic. So there is no reason why it is the vascular supply is decreased, or it can be sickle cell disease. So in case of sickle cell disease, sickle cell anemia, hemoglobinopathies, or it could be trauma. The trauma also result in avascular necrosis, or it could be Caisson's disease. So Caisson disease is one, deep sea sickness. So Caisson's disease is one where you see there is again the avascular necrosis. No, this question, the answer is avascular necrosis. Okay, so these are some of the causes. Okay, some of the causes of avascular necrosis is nothing but it is a damage or necrosis of the femoral head because of vascular supply, and this vascular supply can be reduced because of no reason. That is, sometimes usually the patient presents with AVN, the answer is idiopathic, or they can have hemoglobinopathies like a sickle cell disease or trauma. They can have traumatic causes, or they can have Caisson's disease, right? And this could be because of ischemia directly, okay, where there is decrease, or because of thromboembolic phenomena. Okay, two factors. So thromboembolic phenomena, whenever it is involved, you can see this thromboembolic phenomena again in case of people with SLE. Okay, lupus. Okay, so these two are the pathology. So thromboembolic phenomenon and ischemia because of decreased vascular supply. So all this will happen and will result in what is called as AVN, avascular necrosis. And this is a disease, it is a progressive disease where you see stages. So the first stage, again because of vascular supply, there will be inflammation which is happening, right, and then after that there will be second stage where it is sclerotic, so there will be sclerosis which will happen. Okay, third stage, it will go into stages, it will go into the stages, and first is inflammation, then there is a reaction that is in the form of sclerosis, so then the deformity will enter. So the head will become deformed, so the sphericity is lost, and finally it will result in osteoarthritis. Okay, so these are the changes which happen. So first there will be inflammatory changes, then there will be sclerosis, increase in the density, then there will be resorption, that is the deformity, the sphericity of the head is lost, and finally there is the osteoarthritis. In this condition, if you see, there is lot of sclerosis which is there on the x-ray rather than the osteoporosis. The tuberculosis of hip, mostly you will see the osteoporosis, and this sclerotic stage is because of the, and in the sclerotic stage you will see what is called as the subchondral cyst. So remember, whenever it is a subchondral cyst, okay, and then here in the deformity what you see, loss of sphericity of the head, sphericity of the head, and the classification is Fickett and Arlett classification. Fickett and Arlett grading system, where you see grade 1, grade 2. Grade 1 is usually normal, nothing is seen. Grade 2 again mild sclerosis you will see. Grade 2A you will see the cyst. Grade 3 you see loss of deformity, that is loss of sphericity of the head. So head is not round as you see. And grade 4 you see involvement of the acetabulum which will result in osteoarthritis. But up to grade 3 you see that space is maintained. So AVN is a disease which is from center to the, from the periphery to the center. Matlab joint is not involved early. So joint space is maintained, but whenever it is osteoarthritis of hip or your TB, first joint is involved, and there will be lot of osteoporosis. There will be regional osteoporosis in case of your tuberculosis of hip. So the answer here is your avascular necrosis. And what is the treatment of avascular necrosis? You will go for replacement of the head, that is total hip replacement. And how do I investigation of choice is important here. The MCQ here, what they ask you is the MCQ is the what is the investigation of choice. So the answer here is MRI. So on the MRI you will find out the avascular necrosis. So investigation of choice is important. Okay, Fickett and Arlett, and there are 4 stages, and it is a progressive disease, so you have to treat it. Clear? Yes, final question, but very, very important question. Patient with tibia fracture after 12 hours becomes unconscious. So there is some neurology or coma and axillary petechiae which is present, breathlessness. What is the diagnosis? Very important, the complications of fractures. It is very, very important. And here they are telling specifically after 12 hours. So usually this is fat embolism. So whenever you deal about fat embolism, it is associated with the long bone fracture. So you have to see the long bone fractures, right? And this will release the fat, and this fat will cause some inflammation. So this has to take time. Okay, so this has to take time. So that is why it is usually seen after 24 to 72 hours. So after trauma, there should be a gap of 24 to 72 hours, and there is a triad of involvement of 3. So first is your pulmonary, right? Then you have your pulmonary complications, then you have your neurological complications. The patient presents with all the symptoms. So pulmonary, neurological, and there is a fat embolism. So there is an involvement of the blood. Okay, the fat globules will sit in the blood and they'll cause systemic cause, and they might result in retinal hemorrhages as well. So retinal hemorrhages, pulmonary, there is a breathlessness, and then you have your neurological, that is they have they might go as into coma, or they have some anxiety, or they have irritability. More commonly it is irritability, and then you have your respiratory. Okay. Okay, so that is respiratory, you have the SOB. So all this triad will go sit and diagnose you with the fat embolism syndrome. So this is the answer. So what is the answer for this? The fat embolism. So usually the patients first they will have trauma, and after trauma what will happen? There will be a fat which is released into the blood, right? So this fat which is released, this fat globules will cause certain inflammatory reactions in the capillaries. So which capillaries usually? So these capillaries are usually in the lung and in the brain. So now they present with symptoms of pulmonary complications such as your breathlessness, and brain they produce as irritability or coma, and then they will have petechiae. Okay, so the symptoms of petechiae and retinal hemorrhages is usually seen as fat embolism syndrome, right? And D dimer is the one which is elevated. So D dimer is the one which is elevated in the fat embolism, and what is important is it is seen after 24 to 72 hours. So there is a gap which is present. Okay, and this is most important complication. You have to diagnose it as the fat embolism syndrome, usually done clinically. Okay, then what is compartment syndrome? You know what is compartment? The pressure increases because of the certain factors of where there is rise in the pressure in the compartment. Okay, and you have to be, this is also very clinically diagnosed, very careful. And most important complication is the shock. So there is a loss of blood with the fracture. Patient usually results in hypovolemic shock, and so hemorrhagic is again because of there is a loss of blood. Okay, so these are the complications which are very important. Fine, is that clear? So this is about your PYQs. Hope we have done. And finally, I want you all to answer this. The anterior dislocation of the shoulder will result in which of the following damage of the nerve? Is it the axillary, median, radial or suprascapular nerve? So we already know, we have seen the anterior dislocation of the shoulder, right? And whenever it is coming anteriorly, there is a damage to this nerve. So answer is your axillary nerve. So axillary nerve supplies what? Axillary nerve supplies the deltoid. So deltoid and your teres minor. Okay, it supplies teres minor and your deltoid. And here what happens here? Deltoid is mainly for your abduction. So a loss of abduction. So loss of abduction is seen. And what is your regimental badge area? So what is regimental badge area? So here there is a loss of sensations over this particular area, where is a small patch of anesthesia is seen on this particular. See, this is my puma, that symbol is there, no, here exactly. So here they will, the soldiers are given badges to put here. So this is called the regimental badge area, and there is a loss of sensation in case of axillary nerve. So it is mainly responsible for abduction, that is axillary nerve, and there will be loss of this sensation in the patch. Okay, so that is the axillary nerve damage whenever there is an anterior dislocation of shoulder. Okay, very important again. And when you see radial nerve damage, so that is called as Holstein-Lewis fracture. So that is called as your Holstein-Lewis fracture. So this is also important. So damage of the radial nerve, which will result in what? It will result in wrist drop. So this is important again. Exam MCQ question. So wrist drop is seen in Holstein-Lewis fracture, where the damage to the radial nerve. In the anterior dislocation of shoulder, it is a damage to the axillary nerve. Okay. So medial epicondyle, there would be damage to the ulnar nerve. Fine. So these are some of the nerve damages or the complications seen with the neurovascular damage. Fine. Oh, we are done. So that is it. So you have completed many PYQs right from 2025 to almost 2020. Okay, so some repeated questions I have not kept. So there are repeated questions. So we have done maximum questions which are associated. So from here you have to understand that mainly osteoporosis is one important topic, right? Complication of fractures is one more important topic. You have to read while you're preparing for these exams. Then neurological, that is your nerve injuries. So nerve injuries is very important. Okay, one more important topic for an IC fractures and IT fractures. Okay, so these are the important trauma. That means your trauma. Okay, and recently they have put an attempt to ask the pediatric ortho questions also. So these are certain important things you have to at least revise a day before. So osteoporosis, the metabolic disorders, complications of fractures and the trauma. Usually they ask one question or two questions from trauma, then nerve injuries. one question from nerve injuries, and now they have added pediatric trauma, and one is always about the diagnosis. So how do you diagnose this case? Okay, so diagnosing the case. So what is the diagnostic thing? Either it is CT, MRI, or you biopsy, or CB-NAAT, like that. So diagnosis is very, very important. Fine. Hope you all have enjoyed it. Okay. Any doubts? Raj, thank you. Yeah, the Holston-Lewis fracture is between junction of middle and lower 1/3. So it comes to upper 2/3 and lower 1/3 junction. Yeah. So there is an attachment of lateral intermuscular septum there. So that is why the radial nerve cannot escape. So it gets crushed. So that is called the Holston-Lewis fracture. Okay. Yes. Then any other doubts? Yes, the gluteus maximus and medius are supplied by the superior gluteal nerve. Yeah, the answer is superior gluteal nerve. What else we have left? That HLA-DR3, I don't know. You can leave that. Okay, so any doubts, you can always, we are there for you. You can join our group. I will make sure that it is pinned after this class. So you can put your questions on PW Meded, the Instagram ID, and you can put to my Instagram, that is Dr. Alekhya Ortho. Okay, so your questions will be answered as soon as possible. Any doubts? So if no doubts, shall we end the session? All the best, guys. Hope you'll all do well. Read the question properly, maintain the cool. So everything is understandable there. Everything is accepted, or whatever you do in the exam, like being anxious, thinking about the future, you don't know what to study, what to write, you don't know where you stand. But remember, the end will always be beautiful. So just go with the flow, read the question properly, try to eliminate the options if you have any doubt, and after eliminating 3 options, you try to answer the best one option. Okay, hope this will help you. See you all very soon on the other side. Thank you. Bye.